Good morning and welcome to the externally led, patient-focused drug development meeting on Down syndrome-associated Alzheimer's disease. I'm James Valentine and I'm here in the studio with Candy Pickard, the CEO of the National Down Syndrome Society. We're coming to you live from the Washington, D.C. metropolitan area, actually not too far from where the U.S. Food and Drug Administration's headquarters are located. And it's my pleasure to turn it over to Candy to give some opening remarks. Candy.
Thank you, James. Hello, everyone. Welcome to the externally led, patient-focused drug development meeting on Down syndrome-associated Alzheimer's disease. My name is Candy Pickard, and I'm the CEO of the National Down Syndrome Society. I'm also a mom to 4 kids, and my youngest, Mason, has Down syndrome. The National Down Syndrome Society is a nonprofit organization that was founded in 1979 by a mom that wanted to create a better life for her daughter, Carson, who was born with Down syndrome. That same sentiment drives NDSS today as we work to create a world where individuals with Down syndrome can thrive. Our 4 focus areas of work include resources and support, research, advocacy and policy, and community engagement. This meeting represents an important moment for the Down syndrome community, and it is my privilege to welcome the many staff members of the U.S. Food and Drug Administration who have taken the time to be with us today. Thank you for allowing us to hold this meeting and for your interest in learning from the Down syndrome community. And we are grateful to our project sponsors, ERSCA, Alnylam, Biogen, and Us Against Alzheimer's. We are also pleased to welcome leaders and representatives from all of our supporting Down syndrome organizations, the National Down Syndrome Congress, Global Down Syndrome Foundation, and Gigi's Playhouse, as well as many regional and community-based Down syndrome associations, biopharma companies, and clinical and research centers from across the world. Thank you for joining us. Most importantly, I want to welcome the members of our community whose lives have been directly impacted by Down syndrome-associated Alzheimer's disease, or as we call it, DSAD. We are grateful that they agreed to share their stories, and we are humbled by their courage and determination. Today's meeting is the result of many months of planning and coordination by people working together behind the scenes. We appreciate all who have helped prepare for this meeting. And as a community, we feel the magnitude of the opportunity we have today to ensure that the perspective of individuals with Down syndrome and their caregivers are part of the drug development and regulatory processes. This is especially important because research tells us that 90% of adults with Down syndrome will acquire Alzheimer's disease in their lifetime. And why is that? Chromosome 21 plays the key role in the relationship between Down syndrome and Alzheimer's disease because it carries a gene that produces specific proteins, and it's those proteins that build up over time and cause changes to the brain. And it's difficult to say this out loud, but Alzheimer's disease is now the leading cause of death for adults with Down syndrome over the age of 35. In addition, the onset of Alzheimer's disease occurs much earlier for individuals with Down syndrome, at an average of 55 years old, compared to the general population, whose symptoms typically onset at 83 to 84 years old. And as life expectancy has tripled for our loved ones with Down syndrome, DSAD has become one of the most urgent challenges facing our community. For many families, it is no longer a distant concern. It is the present and it is personal. Today, there's real momentum. Science is advancing. Clinical trials designed for adults with Down syndrome are happening after many years of community advocacy. Yet research can only move forward if families feel informed and empowered to participate, and policies evolve to erase barriers to treatment. One of the cruelest aspects of this disease is how early it arrives for our loved ones with Down syndrome and how quickly it progresses. Today, you will hear from brave self-advocates and caregivers whose lives have been affected by DSAD. Their stories are unique to their circumstances, but unfortunately representative of too many families today. And our caregivers play an essential role in supporting individuals with Down syndrome. Their impact is profound, and the responsibilities they carry can be physically and emotionally taxing. Caregivers, including parents who are elderly by the time their adult receives a diagnosis, are left to navigate complex needs without any specialized support. We cannot accurately measure the extent of the physical, financial, and emotional cost of supporting a person with DSAD, but we do know that the diagnosis has a profound ripple effect on a family over time. Alzheimer's disease has no cure, but the FDA recently approved treatments that are proven to slow disease progression. However, the treatment options are not as clear for individuals with Down syndrome. From a regulatory standpoint, the latest treatments are approved for adults with Down syndrome, but doctors are not prescribing these new drugs yet because of the lack of safety research in this population. And I wanted to express my appreciation to the clinicians and researchers who have dedicated their careers to improving the health and well-being of individuals with Down syndrome. They are moving us closer to more clinical trials and treatments for DSAD. Our hope is that this meeting will encourage additional research, foster awareness of the unique aspects of DSAD, and lead to safe and accessible treatment options for our loved ones with Down syndrome and Alzheimer's disease. To our community today, thank you for watching and participating from wherever you are. You are invited to call or write in during the program. We also ask that you stay with us throughout the day and weigh in on the remote polling. We want to hear as many perspectives as possible, and we'll do our best to get to as many calls and comments as we can. Be assured that any comments we are unable to share live today are still very important and will be included in the Voice of the Patient report, which will be delivered in the next few months. To begin today's meeting, I'm delighted to introduce our speaker from the FDA, Dr. Teresa Baracchio. Dr. Baracchio is the Director of the Office of Neuroscience and the Center for Drug Evaluation and Research at the FDA. She will provide some opening comments from the FDA perspective. Dr. Baracchio, thank you so much for being here. I'll turn this over to you.
Good morning, and thank you for that kind introduction. My name is Teresa Baracchio, and I'm the Director of the Office of Neuroscience and the Center for Drug Evaluation and Research, also known as CDER at FDA. First, I want to thank the members of the patient community who are participating in this meeting and sharing their experience with us today. Hearing about the lived experiences of the patient community is invaluable to us at the agency, and it is very impactful for our decision-making. I also want to thank the National Down Syndrome Society and its staff who were involved in the planning of this meeting. We have many staff members from FDA who are joining the conference virtually today, or who will be listening to the recording later. This includes staff from my own office, the Office of Neuroscience and CDER, as well as colleagues from other offices and medical product centers at FDA, including the Center for Biologics Evaluation and Research and the Center for Devices and Radiological Health. FDA shares the patient community's commitment to facilitate the development of safe and effective medical products for Down syndrome-associated Alzheimer's disease, which I will refer to as DSAD for short. I want to clarify that when we say medical product development, we mean the term broadly to encompass the identification, development, and evaluation of potential therapies, devices, or diagnostic tools that can help patients manage their condition. While FDA plays a critical role in medical product development, we are only one part of the process. I am glad to see a high level of interest in participants from industry, academia, and other medical product development stakeholders who help to advance the development of new therapies for Alzheimer's disease broadly, and who recognize the importance of ensuring that patients with Down syndrome are included in these efforts. FDA recognizes the devastating nature of Alzheimer's disease. Many of us at FDA have personal experience with Alzheimer's disease impacting family or friends. We also recognize that there are unique challenges in the diagnosis and treatment of patients with DSAD. I'm pleased to share that we have dementia neurologists in the Office of Neuroscience, including me, who have experience treating and evaluating patients with DSAD. Although we do have some understanding of the distinct medical challenges in treating patients with DSAD, we are here to learn today from the experts on the lived experience of DSAD, the patients and their caregivers. We have recently seen exciting advancements in the development of new amyloid-targeted therapies for Alzheimer's disease, and we are eager to apply the insights gained from those experiences to advance the science in the field of neurodegenerative diseases more broadly. We are committed to advancing development of new safe and effective therapies for Alzheimer's disease and ensuring that individuals with Down syndrome are represented in those efforts. Today's meeting plays an important part of that commitment. I will now provide a brief bit of background on how FDA views the role of patient-focused drug development meetings in our review work. A decade ago, FDA started its patient-focused drug development program. As part of this program, FDA began having patient-focused drug development meetings, also known as PFDD meetings. These meetings brought patients, caregivers, and various members of the FDA community together to listen and learn about a patient's experience with their disease or disorder. Since the program began, FDA has conducted roughly 30 PFDD meetings, and we've attended many more externally led PFDD meetings. What we have learned from these meetings is that patients are experts in the lived experience of their disease or disorder, and that patients are uniquely positioned to inform regulatory agencies and provide an understanding of the burden of disease and current available treatments. A product of these meetings is a Voice of the Patient report, which FDA can and does reference for future information when providing advice on a specific medical product development program. We at FDA use these reports to assist us in providing advice to developers of new therapies and in our regulatory decision-making. FDA protects and promotes public health by evaluating the safety, effectiveness, and quality of new products, but we do not develop medical products or conduct clinical trials ourselves. However, it is FDA's responsibility to ensure that the benefits of a product outweigh its risks. Therefore, the conversations that will be had today are extremely valuable for us to hear what patients and caregivers care about. Understanding how patients with DSAD view the benefits and risks of therapies and devices will help us to facilitate the development of these products. We learn so much from these meetings. We look forward to incorporating what we learned today into the agency's thinking and understanding of how patients view benefits and risks of therapies and devices for DSAD. We thank you for your participation. We are grateful to each of you for being here and sharing your personal stories, experiences, and perspectives. Thank you, and I'll send it back to the studio.
Thank you, Dr. Baracchio. And now Dr. Brian Chicoine will provide a clinical overview of DSAD. Dr. Chicoine is the medical director and co-founder of the Advocate Medical Group Down Syndrome Center in Park Ridge, Illinois, and serves the healthcare needs of thousands of adolescents and adults with Down syndrome. Dr. Chicoine earned his medical degree from Loyola University in Chicago, Stritch School of Medicine, and for 35 years he's provided medical care for adults with intellectual disabilities and has presented and written extensively on caring for adults with Down syndrome, including his work as the lead author and reviewer for Care Down Syndrome, NDSS's clinical education hub for healthcare professionals. Dr. Chicoine, thank you for sharing your expertise with us today.
Thank you very much for the introduction, and thank you for giving me the opportunity to be here today with all of you to discuss this important topic. I'm Brian Chicoine, Medical Director of the Advocate Medical Group Adult Down Syndrome Center. And just want to share my disclosures. So as you probably know, people with Down syndrome are living longer and healthier lives than any other time in the past. Just to take a look at the life expectancy curve, I use these 3 dates because in 1907, when my great uncle Leo was born with Down syndrome, although that's not what they called it at the time, his life expectancy was only 9. When I graduated from medical school in 1984, the life expectancy of people with Down syndrome was about 28. And in 2018, the last data that we have, the life expectancy was about 60. So it's been pretty amazing in about 40 plus years that the life expectancy of people with Down syndrome has more than doubled. And that's pretty unusual for any population, and so it's just amazing what this time has been. On the other hand, if you look at this curve, as you keep looking out at the curve, that curve is now flattened, has plateaued, and that is because of Alzheimer's disease. So the life expectancy of people with Down syndrome will not continue to go back up, or will not continue to go up unless we see some real significant improvement in addressing the Alzheimer's disease question. So what do we know about Alzheimer's disease and Down syndrome? Well, first, Down syndrome is the leading genetic cause of Alzheimer's disease. And I like to just pause on that one because I think that's an important thing to consider as we're looking at Alzheimer's disease in people with Down syndrome. The average age of symptom onset is 54 years. So we're looking at 20 years or more earlier in people with Down syndrome compared to the rest of the population. And there's no difference found in the average age of onset in individuals with mild, moderate, or severe profound intellectual disability. So in people with Down syndrome, throughout the range of function prior to developing Alzheimer's disease, the average age of onset is about the same. So in the non-Down syndrome population, over the age of 65 years, about 10 to 11% of us who do not have Down syndrome develop Alzheimer's disease by the age of 65. In people with Down syndrome over the age of 65, it's 50 to 80%, a very significant increase compared to the rest of the population. And the cumulative probability by age 75 in people with Down syndrome is 88%. So again, we're pushing 90% of the population of Down syndrome will ultimately develop Alzheimer's disease. And it's estimated that there are approximately 20 to 30,000 people with Down syndrome who have Alzheimer's disease at any given time. So a very significant population of adults with Down syndrome who are living with Alzheimer's disease. So what are the genetics, and why do we see this so much more commonly at a younger age? So as you probably know, Down syndrome is caused by having an extra 21st chromosome. So trisomy 21 is another name that's used for Down syndrome. So that when people with Down syndrome are born, instead of having 46 chromosomes, they have 47, with the extra chromosome being the 21st chromosome, a third of the 21st chromosome. And we know that the APP gene, the amyloid protein precursor gene, is on chromosome 21. And so that is a factor, a risk factor for Alzheimer's disease. And because people with Down syndrome have 3 of the 21st chromosome, the triplication of the 21st chromosome, they have the triplication of the APP gene. So they have 3 of this gene, where people without Down syndrome only have 2. Other issues that are associated with developing Alzheimer's disease for any of us that are continuing to be studied and certainly need more study in people with Down syndrome are issues of metabolic dysfunction. Some people have called Alzheimer's disease type 3 diabetes, where there's some degree of metabolic dysfunction. And we know that metabolic dysfunction is more common in people with Down syndrome. So what are the exact implications for Alzheimer's disease in people with Down syndrome is still unknown, but certainly the people with Down syndrome would seem to also have that risk factor. And then we also know that inflammation plays a role in Alzheimer's disease. And we know that all inflammation is more common in people with Down syndrome throughout their lives. So again, we don't have the information, the research yet, but it would appear that inflammation probably also, increased inflammation in people with Down syndrome probably also plays a role in this increased Alzheimer's disease. So really, there are some very significant genetic implications for why people with Down syndrome are more likely to develop Alzheimer's disease. So what happens with Alzheimer's disease in people with Down syndrome? So we know that people with Down syndrome have nearly universally have the presence of neuropathology, the plaques and tangles, by age 40. And the presence of these plaques and tangles precedes the symptoms by years. So 12 to 22 years for the amyloid plaques developing 12 to 22 years before the symptoms, and the tau tangles developing 2.7 to 11 years before the symptoms. It is really important to also note that symptoms of Alzheimer's disease are uncommon before age 40 in people with Down syndrome. So if there's any decline in function, particularly at younger ages, it's really important to consider alternative diagnoses. And then the survival after the diagnosis in people with Down syndrome is also significantly shorter. So it's earlier, but also the life expectancy after the diagnosis is shorter in people with Down syndrome of about 4.8 years. And so what are the symptoms? There is some debate in different studies that show which symptoms tend to be first, but several studies show that psychological behavioral changes are the first. So that may be a mood change, that may be a behavioral change. It could be that someone's less cooperative. It could be that they're actually become aggressive. And so those are not uncommon first symptoms. But also some studies show that memory impairment, similar to the rest of the population, will tend to be the first symptoms that are seen. Executive function impairment, so that ability to really sort of manage the day, use all those skills and put them into a functional format. The things that we all are called to do every day, that becomes more and more impaired in people with Down syndrome as they develop Alzheimer's disease. And it's often has some degree of impairment even long before they develop Alzheimer's disease. So that's a common symptom of Down syndrome in general, but also becomes more impaired as time goes on with Alzheimer's disease. And then just the general loss of skills, being able to, how do I brush my teeth? How do I get my shoes on? How do I make my bed? All those things that, we do throughout the course of the day. And many people with Down syndrome can do very well throughout their lives. They begin to lose those skills as part of the symptom onset. It's really important to, as we think about Alzheimer's disease in people with Down syndrome and diagnosing, it's important to realize that we want to look at what the baseline skill level is. So if someone did not have a skill ever in their life, that does not mean they have Alzheimer's disease. It's really the change that's so important, not the absolute skill level. And as the disease progresses, incontinence becomes an issue, gait impairment, which has a lot of implications for falling, for injuries, for inability to participate in activities, which only exacerbates the loss of skills because people can't participate in things. And then seizures are also significantly more common in people with Down syndrome who develop Alzheimer's disease. In fact, it sometimes is actually the first symptom that we see. So a person has not developed any of the other symptoms we just discussed, but they have develop a seizure later on in life that they have not had earlier in life. And then if you wait, then oftentimes you will begin to see these other symptoms of Alzheimer's disease. And then what I call the terminal event is the development of dysphagia or swallowing dysfunction. And as that progresses, people develop aspiration pneumonias, difficulty eating, eating refusal, and so that unfortunately is often the thing that will lead to the person's demise. And how do we make the diagnosis? Now, others are going to talk about this more, but just briefly, really want to look for a pattern to decline as we did the history and physical exam. We want to remember that this is still a diagnosis of exclusion in the sense that we really want to make sure we look at other things, other diagnoses that can cause a similar pattern of decline. So whether it's a B12 deficiency or sleep apnea or depression, lots of things that many of that are more common in people with Down syndrome can also cause someone to lose skills. There are certain lab tests, there's neuropsychological testing, and sometimes it's challenging to get that done in people with Down syndrome. The tests that are done in the rest of the population don't necessarily are not accurate in people with Down syndrome, and sometimes it's difficult to find the other tests that are more appropriate for people with Down syndrome. It may be hard to find somebody that is able to do those tests. And then certainly looking at imaging, CT scan, MRI, PET scan, and this will become more and more important as we continue to develop our understanding of what those mean in people with Down syndrome and Alzheimer's disease, and what those mean with regards to tracking, following up on when people are taking the medications. And then biomarkers, blood and cerebral spinal fluid testing can be very important and is a growing area of interest and a growing area of knowledge that ultimately I think is going to be play a huge role in the diagnosis of Alzheimer's disease, but mostly still at this point is used in research and not in clinical work. And then really important to remember that this is affecting humans. And these people with Down syndrome and their family are really affected by this disease and really alters their life in many ways. So, and the unique thing about Down syndrome and people with Down syndrome with Alzheimer's disease is that they are often taken care of by their older parents. So it's older parents taking care of their children with Alzheimer's disease versus the rest of the population where it's typically children taking care of their older parents. And that certainly has implications, for a 60-year-old man with Down syndrome who's declining, needing more assistance, perhaps having gait changes, perhaps develop some behavioral changes, and he's being cared for by his 85 or 90-year-old mother, and certainly that has implications for not only her health but her ability to provide that service. And sometimes, rather than parents, it is siblings as well, taking care of people with Down syndrome. And this really is life, as I mentioned, life-changing for individuals with Down syndrome and their families. And so really, we really need to look to how we can support them in whatever way that we can. And then the other interesting thing is for a lot of individuals, there really is this anticipation challenge. As we know with any genetic disease where there's a high likelihood of someone will develop the condition based on their genetics. People have this anticipation. Should I do the testing? Should I know what's coming? Well, for people with Down syndrome and their families, this is typically, because it's 90 to 95% likelihood that they will develop Alzheimer's disease, really is not that anticipation with regards to a whether, but when and how, and what does that mean? And this is not just the families. This is people with Down syndrome as well. They are looking around. They are seeing their friends. They are seeing their coworkers develop Alzheimer's disease, and they are anticipating that this will affect them eventually, and what the implications for that are. So I want to just thank you really for the opportunity to be here today. This is really wonderful. I look forward to hearing from families and people with Down syndrome on how this is affecting them, and the importance of the work with the FDA is going to be for their lives and for the Down syndrome community. And again, I just thank you for listening and being willing to participate in this process. And I'm going to hand it back to the studio. Thank you very much.
Thank you, Dr. Chicoine. I would now like to welcome our moderator for today's meeting, James Valentine. James has worked for the last 20 years as a champion for the patient voice as part of the regulatory process. He previously worked at the FDA, where he was a patient liaison, helping to incorporate the patient voice into medical product review across the FDA's various medical product center and review divisions. There, James helped develop and launch the patient-focused drug development initiative. In private practice, James works with many patient organizations to ensure their community voices are heard by decision makers. He has also helped to plan and moderate many of the over 100 externally led PFDD meetings. So I think we're in good hands with James, and I'll let you take it from here.
Well, thank you, Candy. Thank you for that introduction, and it's such a pleasure to be here with this community, the Down syndrome community, this morning. And exciting to get us into the most important part of the program, which is hearing from you. So now that we've heard a clinical overview from a disease expert, we do get to the core of today's meeting, hearing from you, people living with Down syndrome who are both at risk of or experiencing Alzheimer's disease, as well as their direct care partners. Patient-focused drug development is a more systematic way of gathering patient perspectives on their condition and on available treatments. As you heard from FDA's Dr. Baracchio, your input can help inform the agency's understanding of DSAD to inform drug development and review. Let me tell you a little bit about today and what to expect. This morning's meeting is interactive, and so we'll be asking you to participate in a couple ways. But the first thing is that today is structured into two overarching sessions. In our first session, which is this morning, we'll be exploring the patient and caregiver experience with being at risk of and living with DSAD and how those symptoms and health effects impact daily life. In the afternoon, we'll bring everyone back together to discuss your experiences with treatments and strategies to prevent or manage DSAD symptoms. What will those two discussions look like? Well, we'll be using a few different ways to bring your voices into the discussion. We'll be kicking things off both in the morning and afternoon, hearing from panels of people living with Down syndrome as well as care partners. They'll set a good foundation for the discussion, and their experiences reflect a range of those experiences that we know the community has gone through, but we know that they won't reflect the full range of this community's experiences, which is why after those panels, we'll move into a facilitated audience discussion with all of you, people living with Down syndrome and care partners in the audience, which will build on those panels. I'll be asking questions and inviting you to provide a comment. We'll be asking you to state your name, first name only, and providing a comment. This will be able to be done in one of two ways. First, you'll be able to call in, as well as you'll be able to submit written comments, and I'll give you specific instructions on how to do those things when we get into our first discussion. We'll also be using polling questions to help broaden the discussion. We'll be asking our patients and care partners only you'll be able to do this on your phone or in a new web browser along the way. And we'll actually go ahead and get you into the system now, because once you're in that system, that polling system, you'll be able to keep that page up throughout the entire day. And you'll be able to, anytime we go to a question, answer that question. It'll appear there automatically. So at this time, if you want to, on your phone or another device or in a new browser on the computer you're following along today, you can go open up that browser and type in www.pollev.com/DSAD-PFDD. Again, that's www.pollev.com/DSAD-PFDD. Just keep that up. We'll be getting to our first set of polling questions shortly. Again, these questions will be useful to help broaden our understanding of everyone in the audience and help aid in the discussion. I also want to mention that there will be an opportunity to provide written comments for 30 days after today's meeting. So whether you had something that you're participating live today and have something else that you wanted to add that you weren't able to share, or if you're watching this on demand after the live meeting, you can still submit your comments as well. All of today's input, as well as that additional written input, will be summarized in a Voice of the Patient summary report, which will be provided to the FDA and made available online for researchers and drug developers. One last thing before we get into that first set of polling questions, I want to cover some ground rules for today's discussion. We encourage people living with Down syndrome, as well as their parents, family members, and other direct care partners to contribute to the dialogue. Again, you can do that through the polling questions, calling in by phone, and submitting written comments. The discussion today is limited to people with Down syndrome and direct care partners, both those at risk of or experiencing DSAD. We do welcome our colleagues from the FDA, drug developers, and clinicians who are here to listen. Views expressed today are also inherently personal, and the discussion may get emotional at times. And so because of that, respect for one another is paramount. And to that end, we ask that you try to be focused and concise in your comments so that way we can hear as many voices as possible. So let's get into it. Let's go to our first set of polling questions. So again, you can go to that polling webpage, www.pollev.com /DSAD-PFDD. Again, if you can pull up that browser that we were just in, that is pollev.com /DSAD-PFDD. We'll get into these polling questions here. Our first one for today, we want to know, am I A, a person with Down syndrome, B, a parent caregiver of someone with Down syndrome, C, a sibling caregiver of someone with Down syndrome, or D, another caregiver, so not a parent or sibling of someone with Down syndrome. And we welcome families who might be here together. You can use multiple devices. You can work together on a shared device and answering these polling questions, whatever works best for you. We just, most importantly, are looking forward to seeing your responses throughout the day and understanding the experiences of our broader audience. As it stands, the largest group we have represented answering the polling questions are parent caregivers of someone with Down syndrome, about around 2/3 of the audience. After that, we see about 15% are sibling caregivers, and another 15 are other caregivers, other family members, close friends, and the like. If we move to our next polling question. So here we want to know, where do you live? And the options are A, the United States, B, Europe, C, the Middle East, D, Asia, E, Canada, F, Central America, G, South America, or H, some other country or region not listed here. Give everyone a few moments here to answer these questions. Unsurprisingly, the vast majority of our audience is from the United States, but we do welcome those of you who have joined from Canada and anyone that might join throughout the day. No matter where you are in the world, we welcome you and invite you to participate in the dialogue and discussion as well. Go to our next polling question. So from this point on, our questions are geared to be about the person living with Down syndrome, and so we've asked them in that way. But if you're a caregiver answering these questions, we ask that you answer them about the person with Down syndrome for whom you care. So whether that's your child or your sibling for many of you. So is the person with Down syndrome A, female, B, male, C, other, or D, prefer not to say? Okay, we'll give you a few more moments here. You can just click down your selections. There's no submit button, so as you click that, we automatically see that response entered here. Looks pretty even between female and male here, bouncing back and forward. Which one is slightly more represented, but it looks like we have a good balance of people with Down syndrome that are represented here today. We go to our next polling question. So here we would like to ask, what is your annual family's or household's income before taxes? We know that socioeconomic status can impact access to healthcare, amongst many other things, and so we'd like to know, is your income before taxes A, less than $25,000, B, between $25,000 and $50,000, C, between $50,000 and $75,000, D, between $75,000 and $100,000, E, between $100,000 and $150,000, F, between $150,000 and $200,000, G, $200,000 or more, or H, if you prefer not to say. And we'll give you a few more moments here, make sure we get everybody's responses. So as it stands, we have a spread across pretty much all of the different income ranges listed here. We see the largest category, less than a third or about a third at $200,000 or more. But we do see a number all the way from $25,000 to $50,000 up through that $200,000, and a number of folks preferring not to say as well. So thank you for answering this question. We move to our next polling question. Here we'd like to know, how old are you? And again, this is asking about the person living with Down syndrome. So is the person with Down syndrome A, under 40 years old, B, 41 to 50 years old, C, 51 to 60 years old, D, 61 to 70 years old, or E, 71 years of age or older? Okay, for those of you in our audience living with Down syndrome, how old are you? Our care partners, how old is your loved one? Give you a few more moments here. Make sure we give everyone a chance to respond. All right. So as it stands, it looks like we have our largest group represented, a little over a third of our audience who are living with Down syndrome under the age of 40. Or 40 and younger, about a third who are 41 to 50, and under a third who are 51 to 60. No one reporting that they or their loved one with Down syndrome are 61 to 70 years old. Someone reporting that their loved one with Down syndrome or they are 71 years of age or older. All right, if we go to our next polling question. It's our last one for this initial batch. Thanks for bearing with us as we get a sense of who is in our live audience today. Here we would like to know, how old were you when you received your DSAD diagnosis, or for your loved one when they received it? The options are A, before I was 40 years old, B, 41 to 50 years old, C, 51 to 60 years old, D, 61 to 70 years old, E, 71 years of age or older, F, if you don't remember when you or your loved one were diagnosed, or G, if you or your loved one do not yet have a diagnosis of DSAD. Again, we'll give just a few more moments here. Make sure we get everybody's responses in. All right, so it looks like about 60% of our audience are representing those with Down syndrome who do not yet have a diagnosis of DSAD. And then for those who do have diagnosis, we see the largest representation being in the diagnosis in age 41 to 50, and then pretty equal between younger than age 40 and between ages 51 and 60. Nobody reporting a diagnosis after being age 60 years of age. And no one not remembering. So thank you again for everyone for participating in those polling questions. We're now going to move into our first topic of the day. And so I'm going to review some of the questions that will be guiding our discussion that we want you to help answer. And so in this first session, as I mentioned, we're going to be exploring what it is to be at risk for and living with DSAD, including the symptoms and daily impacts. So some of the questions we're going to explore, we want to know of all the symptoms and health effects of DSAD, which of those have had the most significant impact on you and your loved one's life? How does DSAD affect you and your loved one on best days versus worst days? We know that it may not, those symptoms and health effects may vary from day to day. We would also like to know how those things have changed over time, whether it's over the course of days, weeks, or months, or even years. And corresponding to those changes, how has the ability to cope with those symptoms changed over time? Beyond the direct symptoms and health effects themselves, we'd like to know, are there any specific activities that are important to you or your loved one that you or they cannot do at all or as fully because of DSAD? And finally, we'd like to know that many of you, as we saw from the polling, are representing those at risk of DSAD. But even for those of you who are already experiencing DSAD or have experienced it, we know that there's a lot of fears and worries for the future. And so we'd like to understand what you fear the most as you or your loved one gets older and what worries you the most about their condition. So to get us started on this topic, it's my pleasure to introduce our first panel who will be sharing some of their thoughts on these topics. We have Amy and Kate, Lisa and John, Jadine, Karen, and Jean. Amy and Kate, take it away.
Hi, I'm Amy, and I live in Weed, California, and I'm here to introduce my daughter, Catherine, or Katie, who's 45 years old and has been diagnosed with Alzheimer's disease. I asked Kate some questions to help her think about and express her feelings, and these are her thoughts. Thanks for listening.
I used to live independently on my own, and I do laundry, everything independently, and sometimes I get lonely because I get sad every time I do things on my own. But sometimes I just feel like I have real good staff for me to help me to notice the other stuff for me because it's so difficult right now for me. When I'm working or sometimes when somebody always says to me sometimes, Katie, you are different. Yeah, I am different. I have Alzheimer's. And I have dementia. I hate having this all the time in my body. And one of my team right now, one of them is my family is supporting me. I'm afraid of my friend right now. She's having Alzheimer's and dementia, everything, because she's getting around the corner right now. she's not doing good right now. She's not herself right now. 'Cause I'm afraid I might be like her. And I don't. If I cannot live on my own, I'll do things on my own anymore. I just feel like I'm afraid I might die. And I might feel like she might die. And I don't want that. 'Cause I'm not ready to die yet. And I just feel like, excuse my language, fuck Alzheimer's. I get frustrated every day. I don't like having Alzheimer's. And sometimes I get mad. And I don't know how I feel. I hope my brain goes back together. 'Cause sometimes my brain is kind of mixed messages in my head all the time. I was very good at having a long-term memory. That I'm not very good with short memory. I just feel like I don't know where I'm at. I always want to be normal and spontaneous. And I want to be different. I just wish I don't have this disease.
Good morning. My name is Lisa.
And I'm John.
We live in Chicago, Illinois, and we have a 28-year-old son named Jack who has Down syndrome. When Jack was born, we had so many worries. Would he have any friends? Would he be able to go to school with the neighborhood kids? Would people be nice to him? Would he ever be able to live on his own? As Jack grew, those worries were replaced by new worries. But the worry that keeps us up at night is the significant probability that Jack will develop Alzheimer's disease as he ages and lose all of the skills he's worked so hard to acquire and the personality that makes him who he is. How many other parents have to start worrying about the very real possibility that their child may develop Alzheimer's so early in their child's life? Jack currently lives in a group home in Chicago with 4 other young men with intellectual disabilities that is operated by an organization called Misericordia Heart of Mercy. Jack participates in Special Olympics and a performing arts troupe. He holds 2 part-time jobs. He works 2 days a week in a restaurant as a dishwasher and 1 day a week as counter help at a bakery and gift shop. In addition, he is an avid reader and probably one of the few people with and without Down syndrome who can recite Hamlet's soliloquy by heart and name the 5 Watergate burglars. As proud as we are of Jack and what he has accomplished, we live in fear of him being diagnosed with Alzheimer's as he ages. We have known that the odds are stacked against us since Jack was a child. It's not if, but when. We became involved in the residential community where Jack lives when he was 12 years old because it offers a continuum of care and the promise to partner with families to provide the care that Jack will most likely need as he ages and is diagnosed with Alzheimer's.
We also know what an Alzheimer's diagnosis will mean for Jack and our family. We have seen firsthand the devastating impact that this diagnosis has on loved ones and their families. Jack's grandmother was diagnosed 4 years ago, and the personality changes, memory loss, and aggressive behaviors have robbed Jack of the grandmother he knew and loved. A dear family friend was diagnosed with early onset Alzheimer's in his 50s, and we visited him regularly. Jack would help feed our friend as the disease progressed. It is difficult not to let the fear of the future overshadow the present. Jack is physically active and enjoys playing basketball and soccer. The thought of him not being able to play the sports that he loves due to the loss of mobility as a result of Alzheimer's is heartbreaking. Jack is proficient at using technology and staying in touch with his family and friends by texting and sharing on social media. For him to lose those communication skills would not just be his loss, but our loss as well. Jack is independent with his self-care and maintains his own daily schedule. It would be heartbreaking for him to lose the skills and independence that he has worked so hard to acquire. With the exceptionally high risk that Jack will be diagnosed with Alzheimer's as he ages, our hope is that there will be new treatments to prevent or at least slow the progression of the disease. In the past, Jack has participated in several university research studies focusing on language retention in individuals with intellectual disabilities and the mechanics behind the reduced exercise capacity seen in individuals with Down syndrome. We are open to having Jack participate in research and clinical studies and possibly drug trials to help drug developers find treatments that will improve the quality of life of those who have been diagnosed.
Even with all the worries and challenges we faced raising a child with Down syndrome, we wouldn't trade the last 28 years being Jack's parents for anything. He is the jokester, the historian, and the heart of our family. We would like to have many more years with him, but we know that the odds are stacked against us that he will develop Alzheimer's as he ages. It is so sad for Jack and for us.
My name is Jadine. I live in Clearwater, Florida. My son, Matthew, is 51 and receives supported living services in his home close to me. Matt's always needed support to live in his home, but helped with dusting, setting and clearing the table, vacuuming, doing laundry, and making his bed. He loves splashing in his pool, and in 2011 began volunteering at the local VA health center 6 hours each day. For 9 years, he delivered magazines and hygiene supplies to patients, played balloon volleyball with veterans, and loved getting lunch in the cafeteria. In 2014, I got a call from Matt's staff after a neurology appointment. In the 2 or 3 months prior, he had lost interest in his pool and had shown some confusion about how to do his laundry. He began signing that he wanted to leave the VA before lunch. There were moments of self-abuse and agitation in the afternoon, both completely out of character for him. With one appointment and no discussion about likely reasons for these changes, the doctor said, "Matt's nearly 40. He has Down syndrome. Obviously, he has Alzheimer's." My 39-year-old son received a terminal disease diagnosis. For years, I worried about my risk for Alzheimer's because I'd had him in my 20s. Imagine my surprise when I learned that my precious son was at higher risk than I had ever been. I felt lost and alone, full of questions that had no answers. I found social media groups for people supporting their parents and spouses with Alzheimer's. They couldn't understand the devastation I was experiencing. For years, I taught Matt toileting skills, how to walk and feed himself. I taught him how to dress and say the few words he still spoke. With that diagnosis, I was going to watch all those skills disappear. My heart hurt in a way I found indescribable. I connected with the National Task Group on Intellectual Disabilities and Dementia Practices, the NTG, and found their early detection screen for dementia, which allowed me to monitor changes in Matt's behavior and functional skills. When Matt was 41, I started to breathe easier. The neurologist discontinued a medication, resolving the initial concern. Overall, he continued to do well despite some minor changes noted on the EDSD. Still, I looked at everything he did through a dementia lens. Shortly after his diagnosis, I created a Down syndrome Alzheimer's online support group that continues to grow because there's so little information available as we try to find our way. I witnessed families discussing the continuous decline of their loved ones, but I wasn't seeing similar changes in Matt. When he was 47, I finally realized the neurologist had been wrong. And then when Matt was 49, I began getting reports of changes such as gait issues that included stumbles and falls, as well as confusion and difficulty with dressing and personal hygiene. Over a 1-month period, Matt experienced 3 tonic-clonic seizures, strong indicators of the onset of Alzheimer's in people with Down syndrome. Those seizures, which have not recurred, marked a new phase of limitations in his life. Matt enjoyed going out to eat at least once a week. That's become more challenging because of increased incidents of choking. Even coming to join me for supper has become difficult because of the unpredictability of his energy and mood. During the pandemic, we connected via video. I sang, he laughed, made sounds and signs each time we chatted. Our calls are short now. His responses are few, limited to signs for mom and I love you, and sometimes a kiss blown my way. Since he was little, our goodbyes included a kiss and a hug that felt like a soul-level connection. About a year ago, I realized he wasn't asking for that hug and kiss when I left. Of all the changes and losses I've witnessed, this one rips my heart wide open. I know where our path leads. Questions, uncertainty, and second-guessing trouble me. Looking back, I am frustrated, saddened, and angered by the impact of that premature diagnosis. I lost 8 years of peace and experienced 8 years of heartbreak and unnecessary worry. It's a heavy weight to carry, that worry of what happens when Matt doesn't know why the world suddenly feels frightening. Now, with the correct diagnosis and my own aging, I navigate anticipatory grief and anxiety, fueled by a lifetime of devotion that is as powerful as it is exhausting.
Hello, everyone. I'm Karen Gaffney. And as you can see, I have Down syndrome. It is not a disease. I am not contagious, so you won't catch it from me. And one more thing, I certainly don't suffer from it. In fact, the only thing I suffer from is when my favorite basketball team, Gonzaga, loses. Now, another thing you should know about me, besides the fact that I'm a basketball fan, is that I am an athlete. I am a long-distance open water swimmer, a really long-distance swimmer. And I can probably swim much longer and much farther than any one of you here on this call. I would welcome that challenge from any of you, as long as we raise funds to battle the early onset of Alzheimer's disease. Now, before you take me up on that challenge, you should know that I have some pretty big open water swims on my resume, including a 9-mile swim across Lake Tahoe, an 8-mile swim across Lake Champlain, and a relay swim across the English Channel, just to name a few. I also like to tell people that I'm the first person with Down syndrome to escape from Alcatraz. I have done that swim from the prison all the way across the San Francisco Bay 16 times now. And unlike some famous prisoners who have attempted that swim, as you can see, I have lived to tell about it. I swim 2 miles a day, 6 days a week, so that I am ready to push that up when an open water challenge pops up. Now, just so you know, I do more than swim and watch Gonzaga basketball. I have a full-time job at a law firm, I raise the money for my nonprofit by giving talks and workshops all over the country and sometimes out of the country. I am an avid reader. I'm pretty good at jigsaw puzzles and ancient rummy. However, it is important to me that you know that I am not the exception for people living with Down syndrome. Look all around the country and you'll find people with Down syndrome who have graduated from their high schools. Some are going on to colleges. They are actors and musicians, golfers, surfers, hockey players, Ironman triathletes, fashion models, congressional lobbyists, public speakers, hard-working employees, and open water swimmers. This sounds wonderful, doesn't it? Until you realize that this can all be wiped out by the time we're in our 50s. As you know, we are at a much greater risk for the early onset of Alzheimer's than the general population. It is a huge, ugly cloud that hangs over us and our families. I have lost several friends to this disease. One was an athlete just like me. He earned a regular high school diploma and a regular 2-year college degree just like me. He was a personal trainer and a public speaker, and he was only 4 years older than me. We are about to lose a whole generation of adults with Down syndrome to this ugly disease. We cannot let this happen. Do you understand that there are no treatments now for those of us with Down syndrome? I'm trying to do my part to change that. I am involved in a blood biomarker study at UC Irvine. There are no studies where I live, so I take 3 days off from work and fly to Irvine to do that. I tried to get into the HERO study, but it was canceled. And now I'm trying to get into another clinical trial that is supposed to start up soon. I will use my voice and my actions as long as I can to put us on a path to prevent the early onset of Alzheimer's disease before it wipes us out. Please help us burst this huge, ugly cloud.
My name is Jean, and I live in Massachusetts. My daughter, Suzanne, was born in April of 1976. I was a labor and delivery room nurse, and I knew immediately she had Down syndrome. At the time, I didn't know what that would mean for her or for our family. Over time, what became clear was this: her diagnosis was not who she is. Suzanne was joyful, expressive, determined, deeply connected to her community. She worked for over 20 years bagging groceries. She started her own greeting card business, and she had a remarkable ability to connect with people. She rode horses for 17 years. She participated in Special Olympics and grew up into a life of increasing independence. Like so many individuals with Down syndrome, she thrived with the right expectations, inclusion, and support. But I am not here to talk about her childhood. I'm here to talk about what happens as individuals with Down syndrome age. As Suzanne got older, we began to see changes, some expected, some not. Like many others with Down syndrome, she developed early onset Alzheimer's. We knew this was a possibility, but we were not expecting it in her mid-40s. We first noticed small things. Forgetfulness. She would forget to brush her teeth. She'd forget to take a shower. She repeated herself over and over again. She had mood swings, agitation, and confusion. As is often the case, her decline came at the same time my husband and I were facing our own realities of aging. Then my husband was diagnosed with advanced lung cancer. Our lives became a cycle of survival, driving 2 hours each way to Boston 5 days a week for treatment, and also trying to care for Suzanne. My other children flew in, and we would divide up caring for Dad and caring for Suzanne, and we did everything we could to hold things together. But Suzanne began to decline rapidly, emotionally, behaviorally, physically. And this happened as my husband's health declined. She forgot how to dress herself. She mixed up day and night. She called people over and over again, forgetting she had just spoken to them. Eventually, she forgot how to use the phone entirely. She could no longer care for herself. She was confused, agitated, and lost. She was not able to attend her father's funeral. On the day we buried my husband, Suzanne disappeared. We had the entire town searching for her. We eventually found her sitting in my husband's car in the driveway, waiting to go with him to Dunkin' Donuts for her iced tea. Shortly after, she was diagnosed with moderate Alzheimer's disease, and now she was 47. We were told there were limited treatment options. We tried what was available, but nothing worked. Soon after my husband passed, I brought Suzanne home. I converted my first floor office into a bedroom for her. She began to lose her mobility. First, she needed a hand to walk, then a walker, then a wheelchair. She developed seizures. She required full-time care. So I became her full-time caregiver while grieving my husband. She needed help with everything: eating, bathing, dressing. She was fully incontinent, and if she fell, I couldn't lift her. And through it all, she would ask me over and over again, "Where's Dad?" Eventually, I had to make the most difficult decision of my life. I could no longer safely care for her at home. There were no appropriate placements locally. When one finally opened up, it felt like a miracle, and she has lived in her group home for about a year. My daughter is now 50. She is in hospice. I visit her almost every day. After losing her father, she felt abandoned, and I want her to know she is not alone. Some days she recognizes me, some days she doesn't. She has largely lost her ability to speak. Eating is difficult. She requires a Hoyer lift to move her, so I sit with her and I sing to her, and I show her pictures, and we talk about the past. We've made tremendous progress over the past 5 decades, integrating individuals with Down syndrome into our schools, workplaces, and communities. We have not kept pace with what happens next. We're not prepared for aging, we're not prepared for Alzheimer's, and families like mine are left to carry that weight alone. Our story is not unique, and that's exactly the problem. We've learned how to help individuals with Down syndrome live longer. Now we must learn how to help them live well to the very end.
Wow. Thank you, Jean, and to all of our panelists for being so brave and willing to share your and your loved ones' experiences with DSAD and help us get started this morning in understanding that journey. It's now the first time, our first opportunity today, to expand the discussion to all of you, people living with Down syndrome, as well as parents, siblings, and other direct care partners of people living with Down syndrome and DSAD today. If you'd like to share your experiences, we welcome you to call in now and throughout the morning program by dialing 1-703-844-3231. Again, that phone number, you can call in to share your experiences both being at risk for and living with DSAD at 1-703-844-3231. You'll be greeted by our operator who will take down some information, and then I'll be able to bring you into the live program. But to get a sense of the experience of our audience and getting everybody thinking, we're going to kick off this discussion with a couple of polling questions. So if you can go ahead and go to that webpage that you had open earlier. Again, you can keep that open throughout the day. Go to www.pollev.com/DSAD PFDD. And it's pollev.com/DSAD PFDD. Our first question as part of this discussion topic is, have you ever, and you can select all of the following that apply. Have you ever, A, had trouble remembering things, B, felt frustrated that you can't do things you used to do, C, changed what you eat or how you sleep, D, had trouble talking or finding words you wanted to use, E, had trouble walking, F, felt really tired during the day, G, had a seizure, H, not been able to swallow or drink food, or I, felt a change in your mood for no reason. Again, for our, and J, lost interest in the things you used to love or like, like your hobbies. Again, this is for all of those living with DSAD as well as their care partners. You can answer these thinking about your loved one with DSAD. So we'll give everyone here a few moments to work through this question. Again, as you make your selections down the list, they are automatically logged here. And here you can select all that apply. So while we're seeing some final responses coming in, it looks like some of the top categories are, people have experienced feeling really tired during the day and having had trouble remembering things. It looks like we may have, having felt a change in your mood for no reason as a top option. But one thing that really stands out to me is how many of these have quite a few responses, because one thing to point out about this question is even though the percentages you're seeing on the right side are not the percentage of people making a selection, but the percentage of total responses. So you can think of these red bars as kind of a relative ranking, and almost all of them are pretty far to the right here. So people living with DSAD are experiencing such a heavy symptom burden across these different symptoms and health effects. All right, if we can move to our next polling question here. So on this question, we'd like to know which of these things bother you the most, and you can select the top three. You'll recognize some of these things. Here we are asking you to help prioritize and pick which of these things have been the most bothersome, which you just told us about on the previous question. So the options are A, I have trouble remembering things. B, I feel frustrated that I can't go do things that I used to do. C, I have trouble eating and sleeping. D, I have trouble talking. E, I have trouble walking. F, I feel really tired. G, I have seizures. H, I am not able to swallow. I, my mood changes for no reason. J, I have no interest in things that I used to love to do. Or K, some other thing that is most bothersome about you or your loved one's DSAD. And here, now that we're asking people to select the top three, we're starting to see a few things rise a little bit to the top. Some of the most common, most bothersome aspects of DSAD. We see frustration that I can't do the things I used to do, being maybe number one, followed closely behind by having trouble walking, feeling really tired, and mood changes for no reason. After that, having no interest in the things I used to love to do. But again, another thing standing out to me here is just how many different things represent a top three most bothersome aspect for so many people. So while some maybe are more common, we're seeing a lot of different things being reported as most troublesome. So thank you for participating in the polling. Keep this webpage up. We'll be coming to some polling questions a little bit later as part of this morning's discussion. But I would now like to welcome our panel who has joined us by Zoom. These are some of your peers within the community who will be helping share some of their experiences living with and being at risk for DSAD. So welcome to our Zoom panel here. Carol, I'd like to maybe start with you as we're thinking about the range of different impacts of DSAD and what that has meant for people living with Down syndrome. What kind of comes to mind as some of the things that were the greatest impacts in your experience?
Hi, my name is Carol Peterson, and I am from Des Moines, Iowa. And the way I am connected to this community is my husband, Mike, and I were the parents of a daughter named Mia Peterson. Some of you might have heard of her. She was the first person with Down syndrome to be on the board of directors of the National Down Syndrome Society, and she did that for 8 years. Anyway, she was diagnosed with with Alzheimer's disease when she was 41. And she was the youngest person that I'd ever heard of to be diagnosed. And she passed away when she was 47, and she went through a range of emotions and symptoms. And I have to say the very hardest one for her and for us was the loss of her memory and things that that led to, like getting lost in the community and things like that. And also, what was very difficult for us as caregivers was the mood swings that she experienced.
Sure. So, Carol, I'd like to maybe explore and understand some of those experiences a little bit more. You mentioned both for her and for you as caregivers, kind of the first thing being the loss of memory. Was that, how did you, first identify that, for her, or how did she first notice that she was struggling with that, early in her Alzheimer's journey?
She worked at the downtown YMCA, and she would take a bus to a certain point and then have to walk through several streets in downtown Des Moines to get to the Y. And one time on the way home, she got lost. And she called us to say that she didn't know where she was. And that was very scary. Fortunately, her sister was in the car, and we were able to loop her in, and Mia was able to say what she saw so that her sister could figure out where she was and go get her. But that was a very terrifying moment. She's in downtown Des Moines. Where in downtown Des Moines is she? And then after that, she also worked at a grocery store, and she got lost in the grocery store. She had been there in that store hundreds of times. And all of a sudden, she didn't know how to get back to wherever she was supposed to be. So those kinds of getting lost things were the most terrifying for us. I'm sure that all of you can point to times that were big struggles for your loved one with Alzheimer's disease. But for us, that is what really comes to mind, the getting lost part.
And was that something that like progressively got worse and worse, did it get to a point where she maybe wasn't able to be as independent because of she was getting lost? Can you kind of describe what that looked like over time?
Absolutely, that was a factor. Once she got lost in downtown Des Moines, we altered the way that she got to work. She would get rides and things like that, and it really took away her independence. She was so proud of being able to go to the bus stop, take the bus, walk 4 blocks up this kind of complicated route, and she was proud of it. And when we had to start driving her to work, it was less fun for her. And that sense of pride that she had kind of went away. So.
Sure. One more question for you, Carol. Thank you for letting me probe here a little bit. So on the one that you said impacted you as the caregiver more, which was the mood swings, behavior changes, was that something that was apparent early on as well, or is that something that came later in her journey? And could you just kind of describe what that actually looked like, for her specifically?
It was really more early on, partially because her doctor gave her a very light pill that helped her chill a bit. But if something was frustrating to her, she would yell at us, things that she never in her life did. Right. And one time, my husband and I were traveling, and her sister came from Portland, Oregon to Des Moines to stay with her. I actually had a high school class reunion, and so we were going to be gone for several days. So our daughter, who was helping Mia, took her to her favorite restaurant, and Mia became frustrated about things, and there she is in a restaurant acting out, yelling at her sister, and her sister could not calm down the situation. And so that was really horrible for both of them. Sure. And for us hearing about it. Wow. So.
Well, thank you for sharing that and giving us that lens into your lives. Nikki, I'd like to bring you in on this topic as well. As we're exploring some of the things that maybe have been most challenging, most troublesome, what comes to mind for you?
Hi, my name's Nikki Baumer. I'm a pediatric neurologist. I actually spend my professional life taking care of people with Down syndrome, but my biggest inspiration is my sister, Heather, who just turned 50 this past week. And, she does not at this point have any signs or symptoms of Alzheimer's, but it's certainly something that we've worried about basically her whole life. And I think the thing that's most prominent in our minds is that every skill, every aspect of her development was hard earned, and really at a time where my parents were trailblazers, and to have this looming and to know that there's this risk of that independence, those skills, the things that she loved so much being lost is just, it's so frightening. And there's not a day that we don't worry about it. We're celebrating these birthdays. She's so excited about her birthday. The 50th birthday is a huge milestone, but it also is scary. And it's just really sad that we can't celebrate completely unencumbered and unburdened by this risk.
Right. And Nikki, given the risk, and as her sister, how, have you, I guess, are there things that like you're looking for, on the lookout for, knowing that this risk is right there? How does, that, impact, your kind of relationship with her, and just, maybe have there been any kind of, false alarms, so far as you're trying to keep an eye out for this risk that, is so present?
Yeah, we don't live together, so I think that there's an element of just being a little bit further, and I try very hard in the times that we are together, which is pretty frequent. We have a lot of visits and see each other mostly every month. It's really hard to not have a scrutinizing lens and to sort of be inspecting for changes. I haven't noticed them. I also am a pediatric neurologist, and I have to put aside those pieces and really just be a sister and be a family member. But I think that it is hard, and I think she worries about it less than I do and less than my parents do. But she's also had many of her very close friends in the past couple of years be diagnosed with Alzheimer's and pass away. And so I think it's really just always there right under the surface.
Absolutely. Thank you so much. Phyllis and Dave, again, here as we're exploring that, we saw that long list, so many different impacts of DSAD. As you look at that list, was there anything that stood out to you?
Well, good morning. My name is Dave Farrell, and this is my wife, Phyllis. My sister, Teresa, is my guardian. I'm Teresa's guardian. She is a year and a half older than I am, and she's made it a wonderful life of almost 58 years here in about a week and a half. I can really, listen to Carol and Nikki's stories so far and start to think about what life looks like next for her. We are not in any Alzheimer's stages that we've noticed yet. There are moments of some cognition issues, and her trying to remember short term what she had for breakfast or what she had for dinner. But for the most part, she's an extremely social piece of our community here locally. She loves her sports. She loves to cheerlead. This is a picture of her.
This is our precious Teresa. And she is, sorry, I interrupted.
No.
She was actually awarded, we live in a little small town, and she was awarded the cheerleader award because she is the longest standing cheerleader at Lebanon High School, because she started cheering when her little brother was playing. And she knows everybody in town and everybody knows her, and she's almost 58 and still cheering on the sidelines with the rest of the cheerleaders. So that's our precious Teresa.
Thank you.
So to circle back, James, I think right now Nikki's story resonates the most. So, everything we know is just a few years down the road, and we've lost some friends that are dear to Teresa, and she has not handled losses well as most of this population doesn't. They don't understand whether it's been her parents, which has been 12 years ago, or aunts and uncles, but friends. They've gone to heaven, and so that's how we explain things away. And I don't think she can fully grasp the idea of what Alzheimer's or dementia will look like in the near term for her. Fortunately, I have a wife that's her sphere of influence. She is a consultant, and her ties have brought us here to hopefully help all of us get a better understanding of what we're dealing with.
Yeah. And so, Dave, you mentioned, and I kind of want to understand a little better. There have been times where there have been some cognitive, like short-term memory, issues. Is that something that she had is kind of maybe not uncommon for her historically, or is this like something that's new and kind of made you raise your eyebrows a little bit, as you're as you said, resonating from Nikki, kind of keeping that eye out, being a little, having that scrutiny?
I think my discerning eye comes from the fact that Teresa has this unbelievable gift, and I work at a local high school. I'm a high school teacher, and I see a number of people with special needs, of varied diagnoses. But Teresa has this uncanny ability to remember everybody's birthday, and I've never seen anything like it. I can ask her about great Aunt Jeannie, or I can ask her about Phyllis and myself. She knows birthdays, and that started to slip a little bit. I've noticed really particularly here in the last couple of years. And then she's really started to lean on the answer yes, because she knows yes is usually pleasing. So for example, is Phyllis an Olympic swimmer? Yes. Is Phyllis coming over tonight for dinner? Well, yes. So I see that type of behavior the most, James, and I think that's something that's where I've noticed. That's where my lens has gone in terms of how is she responding to outside stimulus, questions like that.
And how long has that been going on? Is that something that you've kind of been noticing for a while, and it's been a little kind of like stable as you've now noticed it, or can you kind of describe that?
Sure, I've seen it the most in about the last 2 or 3 years, and I think particularly the last 6 to 12 months.
Okay, and I guess just to close the loop on this, so far, no other new symptoms, of cognitive impact, no worsening, of that over the last 2 or 3 years.
I'll let Phyllis talk here for a sec.
It's so hard to really figure out what's going on. As Dave mentioned, Teresa is everybody's cheerleader and she's eager to please. And so she smiles, she wants to say yes. I mean, the thing that terrifies us is her going to a basketball game and not remembering someone's name. It's one thing about the birthday. I think she is very proud that she lives in her own house with 2 roommates. She does have full-time care there. One thing we have noticed maybe is that she doesn't always say yes to come over as often as we wanted. So we're in Indiana. We threw a race day party and we said, "Are you coming?" And she's like, "No." And we're like, "What?" Like Teresa would never have missed a party. Now, the good news is David can kind of be like, "What do you mean you're not coming to my party?" And "Oh, David," and then she'll come. Right. But the fact that her first reaction was to stay at home was something that I think was very out of character for us. We haven't dealt with what Carol has talked about in terms of, behaviors that were more aggressive or anything like that. But this more apathy of not wanting to come to a pool party was very unusual.
Wow. Well, thank you both so much for sharing all of that. I do see we have a phone caller that I'd like to bring into the conversation. We have Colleen from Buffalo, New York, who's a caregiver to her 53-year-old brother with Down syndrome. So Colleen, I'd like to, welcome you to the program. Are you with us?
Yes, I am. Thank you for speaking with me. As a caregiver, my brother was a little more difficult to diagnose. He had some autism spectrum regression as a child, so he was no longer verbal. He had some self-abuse. But he was in a group home for many years, and he's stable, flourishing. Then COVID hit at that time. They gave him a premature diagnosis of Alzheimer's after COVID, which was very, very brief, just because he wasn't as interested in his activities. I felt it was more, I knew my brother, we visited all the time. He visited my parents' home. I felt it was more depression from the lack of visitation with his family. We weren't allowed to visit for quite a while. So we sort of ignored that diagnosis at that time, and he seemed to be doing very well after we reestablished the visits. And then about 3 years, 2.5, 3 years ago, he became ill, and he began to decline. He never, at that time, did not get a formal diagnosis of Alzheimer's, but eating sensitivities, little more tired. We saw the decline, and the group home that he was in, they were not prepared to manage the symptoms that he was having. So we made the decision to bring him home and care for him. So the last 3 years, we've cared for him at home. The biggest challenge, I am a medical professional, the biggest challenge I found was they didn't even want to seek a diagnosis of Alzheimer's for him. He developed seizures, severe spasticity, and then eventually severe agitation, which was very difficult. All those symptoms were, a lot of discomfort. Those were the most challenging, where we did feel all alone, trying to manage these symptoms with nobody, a neurologist. We even went to the Alzheimer's Center of Excellence hoping to find some help with managing these symptoms, and there was no help offered. And basically I was told that we had to continue going to the neurologist for his seizures, another neurologist to manage the Alzheimer's, and even trying to set up palliative care for him, and then eventually moving to hospice care. It was a challenge that we had to navigate on our own.
Yeah.
There just wasn't the help.
And Colleen, you mentioned
manage these symptoms.
Yeah, Colleen, you mentioned quite a few. I mean, this resonates with one of the polling questions we saw earlier, where there was, such high rates of so many different symptoms being reported. It sounds like, for your brother, he, has experienced, many of the physical, some of the, cognitive, also behavioral impacts with the agitation you mentioned, but this is all being very recent in the last few years. Was the group home he was living in, I know you said they weren't able to provide care. Were they able to, identify, pick up on, the first, kind of signs that he was experiencing Alzheimer's, and what were those first ones?
Well, one of the things, he had a lot of systems that were affected. So one of the things that he had severe GI distress and pain and discomfort. They were dismissing that. They were trying to say it was behaviors.
Okay.
And that was one of the big reasons we pulled him out of there, because we could not see him suffer.
Yeah.
And we knew that even though he couldn't verbally tell us he was in pain, we knew he was having pain.
Right.
And so we brought him home, special diet. He developed sensory texture sensitivities, which he had as a child, but not as an adult.
Mm-hmm.
Foods that he previously enjoyed, he was having difficulty, so we didn't know if it was dental discomfort or just texture sensitivity. So, we knew he needed a special diet to, combat these concerns, but they weren't interested in exploring what was best for him.
Right.
So, we made the decision to bring him home. We developed a special puree diet with whole foods to try to decrease the inflammation and try to minimize his pain. One of the things I realized taking care of him, because I kept a very close journal, was that towards the end, and he just passed away 2 weeks, not even 2 weeks ago.
Oh, my goodness.
Every little sensor or trigger for discomfort was compounded. So his brain was no longer able to detect or sense. There was a discomfort stimuli to the brain, but he could not define. Even, he was nonverbal, but he could not define what that trigger was. So that would trigger.
Yeah.
So if he was soiled,
right,
or he had a little GI discomfort, needed to have a bowel movement, thirsty, little back pain, head pain, that would come out as, he'd start getting agitated, wake up out of a sound sleep. And it started with one night a week where he would do that, wake up in the middle of the night. And if we didn't manage those symptoms, so we would have a checklist of, and try to anticipate what the trigger was. So we would make sure we gave him something for pain. We'd change his diaper. We'd reposition him, make sure he was warm enough. But if we didn't intervene, it would escalate into a crisis where he was having, extremely diaphoretic, sweat and labor breathing, heart rate 150s. It would be a crisis if we didn't try to intervene.
Wow. Oh my
and then
goodness,
as
Callie.
time went on, it got worse. It became a daily thing.
Wow.
Callie, even when he was hospitalized with aspiration pneumonia, because then it became very difficult for him to swallow. Doctors were able to see what this agitation and these triggers, what they would come out as. So it started out as a little bit of agitation, and it increased.
Oh my
so
goodness.
I don't know if
Yeah.
other people experience that,
Right.
but that was some of the symptoms that we saw, and the severe spasticity started out when he started having seizures.
Yeah, so much.
Spasticity. Each time he'd have a seizure, the
Yeah,
spasticity
thank you,
would worsen.
Colleen, so much. Incredible, and I'm so sorry for your recent loss of your brother. But thank you for being willing to call in and share so much of his journey and experiences both early on and in the experience in bringing him home and caring for him. Incredible to hear all of that. I do want to come back to our Zoom panel here and continue this discussion. Of course, we're hearing so much about some of these, so many different symptoms, but a number of different things have popped up for different families of what has been most troublesome. Sonia, I'd like to come to you and give you a chance to weigh in on this topic. If you think about your family's experience, what was most troublesome to you.
Yeah, I'm Sonia Rasmussen. I'm a pediatrician and clinical geneticist, and much of the inspiration for my career is my brother with Down syndrome, who was 2 years younger than me. And I think the hardest thing for us was that he had beat so many odds. When he was born in 1960. It was a different time, and my parents were encouraged to put him in an institution. My mom said, well, we're going to give it a try at home. And, the doctor was pretty negative. You're going to ruin your daughter's life and my life. Obviously, he didn't succeed in doing that. I think he had been able to go to school, even though there wasn't even a class for him when he first went. He was able to eventually get a job. He lived completely independently on his own, and then to lose it all it just seemed particularly tragic. And that was, I think, the hardest part for our family, is that he had accomplished so much with the help of my parents especially, and to lose all that at the end was really hard.
Yeah, it is very hard. And Sonia, as you think about his experience with Alzheimer's, are there certain aspects or symptoms of Alzheimer's that you think most contributed to, stripping him of himself and everything that he had worked so hard for?
Yeah, he was, he had 3 jobs, and he lived in an apartment building and would walk to his jobs each day. And I lived a long way away. He lived in Minnesota. I lived in Georgia, and I had noticed when I saw him at Christmas time that there were some concerning. I listened to Nikki and to Phyllis and Dave about watching everything. You watch everything so carefully, and you're so worried. And my parents were completely, no, he's just fine. Everything's fine. And one day in Minnesota, it's dark sometimes at 4 p.m. He went to work at 4 a.m. instead of 4 p.m. and actually was found on the street hypothermic, because it was Minnesota and it was in the middle of January, and it was the most terrifying thing. And that was when I knew that this was really the diagnosis. But my parents, said anybody could get confused with that. He just set his alarm wrong. It was fine. And eventually I had to fly home, take him to the doctor with my parents, and so that they would accept that this was really happening. And eventually his job that he was so proud of, he was the proudest McDonald's employee ever, said he wasn't going to be able to work there anymore. So that was really hard for him and for the family, because it was such a source of pride for him. And for a while, he was still able to live on his own. We had a retirement party, and he saw that retirement parties were part of life, so he was very proud and had this retirement party and seemed mostly okay there, but it really went rapidly downhill from there.
Yeah. And in terms of, that the progression that happened after his retirement party, can you kind of talk about, some of the things that either emerged? Were there new symptoms, popping up, or was it just really a worsening of, some of those same issues he was already experiencing?
I think it was pretty rapidly. My mother called it walking off a cliff, that he just really lost so much. He lost a lot of the joy in his life. He started having seizures. He started having, the worst part for us was that he started having sort of hallucinations of the people that had made fun of him in high school. He remembered their names, and he, get away from me, stop hitting me. And I think we had felt like when he was in high school that he was handling it better than we thought he was, but clearly that made it obvious that those mean kids in high school that I still want to go back and hurt, that they were really bothering him, and he started having sort of hallucinations that was back. So that was really, really awful. And for a while he moved in with my parents, who were in their late 80s, and they were snowbirds. They were traveling back and forth between Florida and Minnesota, and then eventually he had to go into a care home.
Wow. Absolutely heartbreaking. Sonia, thank you for being so willing to share that and, help us, just understand how terrible, Alzheimer's can be for people living with Down syndrome. I do want to broaden the discussion a little bit. We've heard some already about how, these symptoms, health effects, impacts of DSAD have impacted daily life, but we want to kind of ask about that directly. And so we're going to just shift gears a little bit into polling. Before we do that, though, I do know that we've been getting some written comments on this topic of symptoms and health effects. So, Candy, you want to check in and see what we're seeing there?
Absolutely. Thank you, James. I think that there's one comment that's come through that I think is really valuable and important to share with all of you. And this is from a self-advocate's perspective. And it's from Catherine from Weed, California. And she states that finding my words is very frustrating. Sometimes I cannot even say things, especially on demand. The words just get stuck. And when I want to say a lot of things, the words get trapped inside my head. She also shares that I have a lot of anger and anxiety. Sometimes I just want to hit things when I want to say bad words, mostly when I'm trying to find my words, and definitely when I feel like I don't have control of my own life anymore. And lastly, Catherine adds, I hate this for my life. I just don't like myself anymore. I hate what I'm becoming. This disease is killing me. And I just want to thank Catherine for sharing that comment.
Thank you. And please keep the written comments coming. We'll be sharing those throughout the program today. I know if we don't read your comment out loud today, that we did receive it, and we'll be including it in the Voice of the Patient summary report. So at this time, open up that web page, whether that was on your phone, on a new tab on your web browser. That's pollev.com/DSAD PFDD. And we have one polling question for you here that focuses on the impacts on daily life. So on this question, this is for people living with Down syndrome and their caregivers. Are there things that you used to do by yourself that you can't do anymore? Select the top three. So the top three things that you, if you're living with Down syndrome or your loved one, can't do anymore. The options here are A, I can't take a shower or get dressed or use the toilet without help. B, I can't talk like I used to. C, I don't participate in activities, programs, or sports anymore. D, I can't eat without help. E, I have trouble walking. F, I don't visit with my family and friends as much as I used to. G, I can't do my job like I used to. H, I don't live by myself anymore. Or I, other. Some other thing that you or your loved one used to be able to do by yourself that you can't do anymore. And again, please select the top three things that you are not able to do, the most important things of those. And we'll give everyone a few moments here. We want to make sure everyone has a chance to respond. As it stands, it looks like some of the top things that our audience has not been able to do anymore as a result of DSAD are participating in activities, programs, or sports. And then some more kind of fundamental activities of daily living, showering, getting dressed, or using the toilet without help. We see having trouble walking, reported up there. But again, every single thing here, including some others, are being reported as a top three activity that the person with DSAD is no longer able to do anymore that represent a top impact. So thank you for everyone for participating in that polling. Now I'd like to kind of continue this discussion of some of the greatest impacts of DSAD, as well as, through this lens, if possible, of impacts on daily life. And Makini, I want to maybe start with you on this topic as you're thinking about your family and the future. How do you think about the possibility of onset of DSAD and how it might impact life?
Thank you. Hi, everyone. My name is Makini Anwishe. I am the Adult Services Coordinator at the Gateway Down Syndrome Association in St. Louis, Missouri. And I am the proud mother of a very sassy 35-year-old young woman who does all of the things that all of your loved ones are doing in life. But I just like to share a story to kind of answer your question, James, about how this affects us who have not yet had to walk down this path. We have a program here, and we had three older adults that came to our program all the time, and my daughter was also a participant. And so one day she saw, and I'll just use his name was John. And John came in one day, and John was different. And John couldn't find his way to the bathroom. So my daughter, who has the heart of a servant, she just, come on, John, let's go. We're going to the bathroom. And so she got him there, and she said, shut the door. I said, okay. And so about 20 minutes later, she said, I think somebody needs to go get John out the bathroom. So I went and knocked on the door. And I said, John, can I come in? And he said, sure. And John was still standing. And he said, where am I? What am I doing?
Oh, my goodness.
And so we were able to help him to do what he had to do. And so when we came out and came back, my daughter asked me what was wrong. And so I knew that he had gotten a diagnosis. So I said, well, we'll talk about it. And we talked a little bit about that. And she said, that makes me really sad because am I going to get that? And as a mother, when your young adult asks you, am I going to get that? I said, well, we know good doctors and we lean on our faith. I said, and I don't know who's going to get what. I said, but we're going to continue to help our friends that are here
Yeah.
to continue to be the best that they can be. So she became that one-on-one when John would come or when one of our other older adults would come. So when I think it was Jaden said, we look through the lens of this dementia. So we kind of live that life. So we see, and in some ways, I think that our loved ones live through that lens too, the more that they know. So it's not, we don't want to live as if there is no hope,
Right.
but we do know that it is there.
Yeah. And as she gets older, and I guess how's your collective, her and yours together, ability to kind of cope with that risk, that seeing it day to day like you do, how has that ability to cope changed, and how has that impacted her at all?
I think I know a couple of years ago, she went through some health issues, and the health issues were the symptoms were things like I tell her to do something and she wouldn't do it. And so you began to think like, is this like behavior, or is this so sorry, something a little bit more? And so once she got past all of that and we found out that there was some physical things going on, now whenever I ask her to do something and she doesn't do it right away, she said, Mama, I'm not showing signs. That is, I'm not showing signs just yet. So let's just go on. But again, that's that lens, that's that shadow that is there. And Nikki, I think you said it. It's like no matter what you're doing, we're having fun. But you begin to think somewhere along the line, 35 is not that far from, 40, 45, 50.
Right.
And so
Absolutely.
it does color sometimes.
Absolutely.
What
Already.
you're saying you do.
Already. Wow. Thank you so much. Carol, I want to bring you into this conversation as we're kind of now thinking about how, daily life, quality of life, was impacted. You shared, some of your daughter's, experiences in terms of the DSAD. As you're reflecting, what were some of the biggest impacts on, activities in daily life, things that maybe became impossible to do? Oh, and you're on mute.
So, first of all, Mia was a very independent person. She lived for 10 years in Cincinnati, Ohio, 700 miles away from us. And then when she moved to Des Moines, she had her own apartment. So when she could no longer live by herself, that was a huge impact on her. She resented us, but there were I wouldn't say that she was mean or anything like that. You could just tell it really weighed on her that she had been so independent, so accomplished, and to have to suddenly move in with your parents, that seemed like a low blow to her.
Right.
And also, she was into sports of any kind. She was a big Iowa State basketball fan, and she liked to do anything that allowed her to participate in running activities. She did some 5Ks, and she wanted to go to any kind of programs where there was physical activity involved. And it turned out that she had to curtail those activities. She pulled back for a while and then just couldn't participate in them anymore because she didn't have the physical capacity. And that was very difficult for her.
And Carol, I mean, hearing that she was so into sports, so into physical activity, what types of things, maybe it was a 5K, you mentioned that specifically, but whatever it might be, what was it, how was she participating? And then, she and you and the family noticing that, she just wasn't able to do so the same way. What did that look like?
She became involved in some kind of a group activity that I'm sure many of your loved ones have done, where there were group activities where you could do basketball, play volleyball, and then it even got to like balloon toss kinds of things. But she went more from being able to do activities that your typical kids could do to doing less and less. And finally, like the only thing that she could do was a little balloon toss game while sitting in a wheelchair. She loved it, but it just became more and more restrictive as she became less and less able.
I see. And
Does that answer your question?
No, it really does. Just one more quick follow-up on that. So it certainly sounds like it wasn't, a pulling back due to a lack of interest or, apathy
Absolutely.
setting on.
Right.
But there was physical impacts. Can you just kind of, help us understand what those were?
Well, she used to walk to church 1 mile every week, and as she was getting lost and things like that, we curtailed that and we didn't let her participate in races or anything. And so as she still was doing lots of walking, I would walk with her.
See.
And the activities that she would do would not be in typical settings, but they would be in more sheltered settings like group activities designed specifically for people with disabilities.
Right.
And I don't think she disliked that, but it was obvious that her abilities were becoming less and less. One thing that I didn't mention earlier that I should have,
Sure.
Mia was, I said, diagnosed when she was 41. She was on the board of directors of the National Down Syndrome Society. I was a special education teacher. We were well aware of this possibility, but we were blindsided. We never thought of somebody at the age of 41 being diagnosed like that. So I thought that was something I should probably mention, that not everybody is just anticipating this is going to happen.
Right. Wow. Well, thank you for sharing that as well, Carol. We do have a phone caller I'd like to bring in the conversation. We have Becky from Tucson, Arizona, who's the parent and caregiver to a 20-year-old. And so I want to make sure that we get this experience, this perspective from a parent of a young adult as part of the conversation. So, Becky, I would like to welcome you to the program. Are you with us?
Yes. Hi. Thanks for having me.
Yes. Welcome.
Oh, and you can hear me okay?
Yes, we can hear you clearly. Would love to hear
All
what
right.
you'd like to share.
Well, yes, my son is with Down syndrome, is 20 years old. He's our only child. We are older parents. We were 43 when we had him, so we're in our mid-60s now, and he's 20. And just to express that, our life has been all for the better since he was born. We thought we weren't going to have any children, or that we couldn't have children. We had tried and tried and tried, and then he was born. And so we were thrilled with that, and we have been, our lives have been made better, as everyone knows, with this, and have shown us a side of life that we're very blessed to have known. I have a diagnosis of generalized anxiety and panic from the past, and so I am on medication, just a dose of Lexapro, changed every now and then, but I certainly understand the feelings of anxiety, and I haven't experienced panic in a long time, thank goodness for medication. But I have experienced it, and I started noticing in our son that he had anxiety in certain situations, with crowds, with loud noises, and things like that, which, had I not already been diagnosed, I might have considered that as part of Down syndrome. And I'm not saying that maybe anxiety isn't something that is elevated or exaggerated. I can't think of the right word. But anyway, I noticed that, and I feel blessed that I'm able to, have gotten him involved, and it's important for us, especially being in older parents, that when he turned 18, I decided to go ahead and get him established with a behavioral health specialist, and get him on a low dose of some kind of medication to see if that helped, and also see if it, how it might help him in his daily activities. And right after we put him on a very low dose, the people at school, because he's very social, even though he's an only child and he appreciates his time by himself doing what he likes to do, he's very social and he wants to have friends, and he does have some friends. And most of his socialization was in school and now is in his vocational training programs. He's a hoot and he's a jokester. As soon as just a few weeks after he started the medication, I mentioned to the teacher, I said, just want to let you know that he had started this medication, and if you notice any changes, let me know. And she said, oh, we've already seen changes. We've already seen how he's coming out of his shell, how he's participating more. He's even more goofy than he was. But this leads me to talk about dual diagnoses. And I had a mother-in-law. My mother-in-law passed away from Alzheimer's. And that's one of the things that we learned with her is that to be cautious, that we learned from our specialists, is to be cautious that, sometimes in the course of the Alzheimer's, depression, of course, can occur and everything, and that some symptoms that might be written off as, oh, that's just part of the Alzheimer's, may not really be. It may be depression. It could be the anxiety that can be treated with something besides Alzheimer's medicine. And so because of that lesson with her, which was back when my son was 10, I keep that in the forefront of my mind, that that individuals who are going through Alzheimer's, I'm sure, can also be going through depression and anxiety, and that can be treated, and it can be treated successfully. So I just wanted to share that with parents, that's the fact that we're older parents, I do kind of live in fear that we're going to be gone if and when he goes through Alzheimer's, that we may not be around to give him the assurances. We're also, both my husband and I are the youngest in our family. His four first cousins are all 30 years older than him. And so there's not a whole lot of family that he's familiar with. And so that, just talking about the dual diagnosis and then talking about being able to express our fear of what to do when we're gone. So we spend a lot of our time, doing research and figuring out where he might live after we're gone, and that it is something that we feel confident that they will be able to take care of something like this if it were to occur for him.
Well, Becky, thank you so much for calling in and sharing both of those things. We've heard already today about the challenge and pressure to monitor her, for signs of Alzheimer's, and, adding on, comorbidities, on top of that, things that might have overlapping symptoms. I think that's really important for us to hear. So thank you so much for sharing that, as well as, your worries for future and caregiving. We do have another phone caller that I'd like to bring in. We have Gary from Palm Desert, California, who's a parent caregiver of his 43-year-old daughter with DSAD. So Gary, I'd like to welcome you to the program and see, are you with us?
Yes, thank you very much for having this, and we really, my wife Lori and I greatly appreciate all the effort everyone's put into this and all the comments. I just wanted to share, Rachel, our daughter, is 43, and some of you may be familiar with her. Rachel was on the show Born This Way, which was a fairly groundbreaking Emmy Award-winning series about young adults with Down syndrome and their quest for independence. So I just wanted to share that Rachel was able to achieve some independence. She ended up moving out right after the show was finished, so she was about 38 at the time, around there, and lived on her own under some supervision, and she also worked at an insurance company for over 20 years, so that was quite good. But we started noticing over the last couple of years that there was some decline with things, particularly with her memory and repeating things. So to make a long story short, we moved her back in with us, and that was about a year and a half ago. And since that time, we've seen many of the symptoms that you've discussed, and she also has been diagnosed with Alzheimer's. And so hearing everybody's story has been very meaningful to us here, and we really just wanted to share this with everybody here because, again, some of you may know Rachel, and we're glad right now that we haven't seen any mood changes. She's still the same sweet person she was, and I think probably the thing that scares us most, besides having to give care if she's incapable of many things, is just we're hoping that her outlook, her sweet outlook on life can maintain. And hearing a lot of your stories about what you've lived with has really mattered a lot to us. So I just wanted to share that with everybody.
Yeah. And Gary, if you don't mind me following up a little bit, I am curious, it sounds like it was such a big, effort and, to have Rachel be able to live, outside of the house. So a big then decision to move her back in. With the memory loss, what were the things that, kind of triggered, making that decision?
I'll have my wife, Lori, who's involved a lot with the various things with Rachel. Go ahead, Lori.
Just a lot of things that she used to be able to do. Her hygiene started going down. She was having trouble washing her hair. Things were changing. She was having trouble picking her clothes out. Just different things, and constantly repeating herself, not remembering things that she just told me a half hour ago. So I just saw a lot of changes.
Yeah, we just no longer felt comfortable with her not being with us.
Right. And so now back at home and with the other symptoms that she's experiencing, could you maybe help us understand what a good day looks like for her versus like a bad day? What's that look like?
I would say a good day, we have her in a program here, which is a wonderful program. She attends it every day for about 4 or 5 hours a day. It's with other young adults, all of whom are female, which they get together and just kind of do their thing. It's a great situation. A good day for Rachel is being busy with things. So when she's doing things, the day goes and things progress. Once she gets home, then it's a matter, she's showing less interest. She used to be able to watch movies all day long. So when things are unstructured and there are not things planned for her to do, she's at a loss. We try to entertain her the best we can, but then at a certain point, she needs to be able to entertain herself. So the bad days, I would say yesterday was not a great day. She didn't have the program. She seemed very tired. She seemed a bit out of it. Today she seems better. So it varies day to day.
Well, thank you both so much for calling in and giving voice to Rachel's journey. So helpful to hear. I do want to check back in and come to Sonia on our Zoom panel here as we're exploring, the impacts, the activities in daily life, quality of life, as you think back, what were some of the things that were most impacted, taken away?
Yeah, I think initially it was the living on his own and having to live with my parents. And initially he took it as, well, this is retirement and this is, mom and dad retired too, and I'm retiring like they are. And initially he didn't feel that it was as bad as we thought. He would be really devastated to not work anymore. But he felt like it was time for him to retire. I'm retiring. Sonia, when are you going to retire? I was working 3 jobs, so I had to retire earlier than you did. You only have 1, so, but I think as time went on, he was unable to make food on his own. He'd really taken fully care of himself for years. It's funny, he still remembered things from our childhood better than I did. And he knew every episode of Gilligan's Island, absolutely everyone. And he remembered what the professor had said to Marianne, and so he continued to remember those sorts of things, but unable to really take care of himself day to day. And had my mom really had to take on all of that.
Sure. Wow. Well, thank you for sharing that. I do see we're getting a lot of written comments on this topic, so I want to make sure we're checking in here. Candy, what are we seeing?
Yeah, we've got some really powerful comments that are coming through. One's from Elizabeth from Moore Park, California, who's a parent caregiver. And she quotes, "My daughter was an independent, active, and competent young lady until 2 years ago when she was 38 and we first noticed symptoms of AD. Because of the symptoms, she's been unable to attend the day program she had attended for over 10 years. And in California, there are limited day facilities to care for her. So we had to keep her home and have little support and are exhausted." Another one from Jenny from the United Kingdom. Jenny states that this experience has been heartbreaking for all of us, not just for the way AD has robbed Liz of her very fulfilling life and us of a very much loved member of our family, but it's also because care provision is so poor. And one final comment, if you don't mind, is Donna from Canada. "On a very rare occasion now, our son will be able to be his old self and be able to leave the safety of his home for 1 to 2 hours. Those occasions are becoming less and less frequent." So we're hearing a very similar message of our panelists and our callers and written comments.
Yes. And again, thank you to everyone who's been writing in. Way more than we can read today, but we are seeing them, and we will be including them in the Voice of the Patient summary report. So I do want to expand the discussion one more time. Again, not surprising, something that's already come up a bit as we've been talking, but we know that there's already so much that people are living with, but both the stress of being at risk of DSAD and then, of course, living with DSAD. But in both situations, that there is also a burden of having to think about and worry about the future. And so we would like to get more perspectives on that topic. And to get us started on that topic, we will go to our final polling question of the morning. So again, you can go to that webpage that you had opened up on your phone, on your web browser, on your computer, www.pollev.com/DSAD-PFDD. And here, our last question for the morning is, we would like to know, when you think about your future, what do you worry about the most? And you can select up to the top 3 greatest worries. Again, this is for people living with Down syndrome, and their care partners can answer thinking about the person living with Down syndrome or DSAD. And here the options are: A, I worry about losing my independence; B, I worry that I won't be able to talk well; C, I worry that I won't be able to connect with my loved ones the same way I do now; D, I worry that I won't be able to think clearly; E, I worry that I might need help walking; F, I worry that I need help eating; G, I worry that I will be sad or anxious a lot; H, I worry that my family and friends will have to help me more; I worry that I don't know what my future holds; or J, some other worry that you have about your future or your loved one's future that isn't listed in the other response options. As you're making these selections, I'd like you to think about, probably you could click every single one of these things as a worry that you have, but what is it that, made you think about the three, up to three that you've selected as being, those top worries? What is driving those worries and concerns? So we'll give everyone just a few more moments, give everyone a chance to respond to this. It looks like, at least for now, the top answer is worry that I won't be able to connect with my loved ones the same way I do now, followed by a worry about losing my independence. After that, there's a bit of a drop-off, but we see others, including worry that I will be sad or anxious a lot, worry that I won't know what my future holds. But every single thing here, again, a theme throughout the day, as being a top three worry for some number of people, including some other things, and we certainly would like to hear about those as well. So thank you for participating in the polling. You can still keep this up. We'll be coming back to polling questions in the afternoon. But if you would like to call in and share some of your worries for the future, I invite you to do so. You can dial in. You've heard some others already call in by phone, so you know what that kind of looks like, sounds like now. You can dial in at 1-703-844-3231. Again, that phone number is 1-703-844-3231. We'd love to have you call in, connect with our operator, and then we'll be able to bring you into the live program. But Nikki, maybe we can start this conversation with you as we're thinking about the future and maybe the things that really are the top worries and concerns, knowing that like I said, you probably could have clicked everything in that polling option off as a worry.
Yeah, I have, the sibling perspective, and I worry about all of these things. And I think on top of that, I worry about, caring for my whole family and caring for my aging parents and then my sister and in the sandwich generation. And I think that is just something that we all have to contend with as a community. It's just so wonderful that people with Down syndrome are living longer lives, but this is a real piece of it that really just impacts, I think, so much of the strides that we've all made as a community. So, I think that there isn't anything on this list that I don't worry about for my sister. And I think that the caregiving piece is a really important one as well, especially for siblings.
And in terms of thinking about caregiving, both, yourself, your aging parents, are there certain aspects of what we've talked about with DSAD today that, is kind of most driving that worry, the thing that might you worry for, your sister, your family circumstance would be the things that might be hardest to handle as a caregiver? How do you think about that?
I think a lot of it is loss of independence. I think a lot of it is also just worrying about, are things better in the environment and the routine in which my sister has thrived for all of her life? Or is a change going to be something that makes it all worse or harder? And how to balance all of those different pieces, I think, is another part of it. There's just so much uncertainty about it. And I think that there's not really a path where navigating it has easy answers.
And just to make sure I heard you correctly, because I think there's something that kind of really stood out to me in what you just said, which is, if there are changes that come as a result of DSAD that disrupts, her routine, and that then itself could, have major impacts for her. Could you just kind of speak to that, kind of help flesh that out a little bit better? So
Yeah, absolutely. And my sister specifically, she is an artist. In fact, I have her art all over everywhere, but she spends so much of her time doing this art. It brings her joy. She sells her art. She teaches art classes. Like many people on this panel have said, there's an aspect of her where she's sort of like the mayor of the community. Like everybody knows her everywhere she goes. Yeah. And that has helped her thrive for 50 years of her life. And so what happens next in this future where if she were to show signs of Alzheimer's, or if my parents were and they were no longer able to care for her, that to me makes me feel like the routine, the environment all would have to change. Like so many people have said, no longer able to live independently, no longer able to do the things that are just part of the daily lives. To what degree does that in and of itself sort of accelerate all the hard aspects of it? And that worries me a lot. If there were a need for her to move to be with me, and then what would that look like, and how would I set up a community or an environment that would work and that wouldn't make things harder. Those are all the things I worry about all the time.
Wow. Yeah. Thank you so much. Yeah. Phyllis and Dave would love to have you weigh in on this topic. What are your greatest worries and concerns for the future?
Well, I kind of want to build on something that Nikki just said about kind of Teresa's impact in our whole community. I mentioned we live in a small town. Everybody knows her. She's been a cheerleader for how long ago were you in high school?
40 years.
40 years. She's been a cheerleader for 40 years. But you know what she's done? She's had this amazing impact on generations of people in our community. Dave's friends, our boys' friends, they have a whole different understanding of someone with special needs because of Teresa and her personality and how warm and open and welcome and loving she is. Sorry. And one of the things that makes me nervous is not just for her to lose that ability, but for the whole community to lose. If she were to get, aggressive or agitated or unable to do these things, there's a whole bunch of people who are going to have a different experience with Down syndrome than what she's left. And I don't want that legacy to be lost. Sorry.
Oh, no need to apologize. Thank you for sharing that. And, it's not lost on me to hear, that, the idea of that relationship with the whole community and knowing what Down syndrome is, and that this completely different disease, Alzheimer's, would come and impact, that how people perceive Down syndrome.
What if people think that that's part of Down syndrome and they don't realize that it's something else to blame? We know that because of the world that we live in, but other people don't. And I'll tell you what, she and everybody's loved ones here are really pretty fantastic people, and they deserve to be able to stay that way.
Yeah. And just to make sure I understand, you mentioned aggressive behaviors. Is that the primary worry and concern then?
I think that's the worry that I have in terms of her impact in the community. What do you worry about most?
We've been really fortunate to have great caregiving. Our local Boone County ARC has done a great job both in the workplace and have set up a home that Teresa's allowed to live independently with 2 roommates, and it's worked really, really well. I'm concerned that they don't have the background, the education that's going to allow them to deal with an aging group of special needs adults. That concerns me quite a bit. And I think the more that we can advocate and really help educate them, it's going to help a ton. And so this panel's been eye-opening on several fronts for us.
Yeah. Well, thank you both for being willing to share. McKinney, I want to bring you in, as you think, about, your mom. So, you are mom. So, Mom, what are your biggest worries and concerns?
Mom worries about the fact that she loves her independence. Although she lives at home, she's able to go places. And again, like everybody said, she's the mayor wherever she goes. I was somewhere and somebody said, "Oh, that's your daughter?" And I was like, "Good or bad?" She said, "Oh no, we just love her. We just love." And that would be so devastating is my word. Devastating if in fact when I would have said good or bad, they would have just kind of dropped their head and said, well, she was kind of not in a good space that day or something like that. So to lose her independence and then to not be herself, to not be who she is, that person that is, she's my rock star. She's our everything. She is all of that you all said. She is the person who everybody get on WhatsApp because today is La La La's birthday, and she'll make sure that everybody knows that that's whose birthday it is. And so for that to just not be there, which is a core component of who she is. Also, the aunt, that she is an aunt. And all of her nieces and nephews are taller than she is. She's literally 4'11", so everybody's up here. But when they see her coming, it's, hey, and then they go and do their thing, whether it's Uno and she'll cheat just a little bit. But they'll all have such a great old time with it, Going to church. Going to church, walked in one day, well, where's your daughter? And I was like, hi, I'm here. I'm fine, doing well. But again, we don't want them to be able to lose that core component of who they are. And we know that that can be a part of it. And so that's a huge worry for mama right here.
Are there particular, symptoms that you think, would most threaten her being who she is?
I think that whole not being able to think clearly and not being able to function, her functionalities, because she's always been able to do things from the time she learned. Like I think it was Carol that said, or maybe it was one of the moms on the videos that said, I taught them how to go to the bathroom. Well, my sweetheart was a pretty nice sized baby when she was born, and we laughed all the time. We said she's got to learn how to go to the bathroom because I'm not going to carry her around. But to think that one of her functionalities would be maybe down the road that something that, and she'll tell you, bathroom, going up, doing all of that, that's a part of her. And so if that was something, that would be sad,
Absolutely.
those kinds of things.
Wow. Well, thank you so much for sharing all of that. Carol, Sonia, I am going to come to you here. I know you're coming from a different perspective. We're not talking about your worries for the future for your loved ones who have passed away, but I would ask that, if as you're thinking and reflecting on, you've lived through it, you experienced it, and including, end of life, which can obviously be an extremely difficult period in the Alzheimer's journey. I just wonder if, as you're reflecting back, I guess, Sonia, will just to give you an order, Sonia, we'll start with you, and then we'll go to you, Carol, for the final word from our Zoom panel here. How did your worries shift as Alzheimer's progressed, and any reflections you have, from end of life?
I think my concern was him suffering. As I remember one of the persons with Down syndrome saying earlier in the time, Mark had never suffered with Down syndrome. He had excelled. He had joy in having Down syndrome, and he didn't think it was a bad thing. When he saw a baby with Down syndrome, he'd say, that baby has Down syndrome too. He was very proud that he had Down syndrome. And I think when I started really seeing him suffer, I think that was when it was hard. And I think I just didn't want to see that continue on for a long time. I think that was the hardest part, when he started having the hallucinations and seizures and really not being himself anymore. Watching that suffering was really, really painful. And it did make it so, he was a very, I'll get tearful here, but he's a very religious person. And, I felt like if anyone's going to go to heaven, he's going to go to heaven, And so I felt like, it wasn't as bad to have him die as it was to watch him suffer. If that probably sounds bad. But anyway, it was so awful watching towards the end. And then I think the hardest part for us was then it was during the pandemic, so none of us could be there with him. We couldn't even get on a plane. So when he was sick, he got very sick at the end and had to be hospitalized, and none of us could be there. They wouldn't let anybody in the hospital. So it made it really hard.
Thank you. Thank you, Sonia. Carol?
So our caregiving happened during the pandemic as well, only Mia stayed with us, so we were with her 24/7 through it all. And so we were really able to see the progression of how she lost skills. You know, it started with the not being able to participate in sports and not being able to continue with her job, but then to not be able to take care of hygiene things herself, and then to not be able to walk, and then to only be able to eat soft foods. She lost every skill. What she didn't lose was her love of music. You know, she'd hear music and her body would be swaying. And Mike and I also believe that until the end, she still knew us because we had the opportunity to be with her every second and care for her every need. So she lost a lot, but we didn't really lose a lot.
Wow, profound. And just, you all have just been so incredible. I'm so grateful to this panel here for everything that you've contributed throughout the entire morning here today. So I just, really want you all to know that you've been heard, and appreciate you as well as all of our callers for contributing. I do know that we have written comments, so we'll give the final word to those who are have been on the web submitting comments that way. Candy?
Yeah. I'll share one from Carol from Willow Park, Texas. So Carol states that my daughter is 12 years old and has Down syndrome. Right now, our focus is education, communication, independence, and helping her build the fullest life possible. At the same time, like many families in the Down syndrome community, we live with the knowledge that approximately 90% of individuals with Down syndrome will develop Alzheimer's disease pathology, often decades earlier than the general population. This really impacts families long before symptoms begin. It affects how we plan for adulthood, independent living, employment, long-term care, financial security, and quality of life. Families are not only concerned about lifespan, we're deeply concerned about preserving cognition, personality, communication, functional skills, relationship, and dignity for as long as possible, which I think is exactly what we've heard today, this morning.
Again, thank you for everyone who's been with us this morning, for everyone from the Down syndrome community, and to everyone who's been here listening and learning, so we can help address these needs for future therapies. And that's exactly what we'll come back to focus even more on in the afternoon, as we're now going to be moving into our lunch break. We will be resuming the meeting at 1 p.m. Eastern Time. You can join back through the same live stream, and we will be building on what we've learned about what it is to be at risk for and live with DSAD, and better understand your treatment experiences and what you're looking for from future treatments. So please rejoin us at 1 p.m. for that discussion. Thank you. Good afternoon, and welcome back to the externally led patient-focused drug development meeting on Down syndrome-associated Alzheimer's disease. I'm James Valentine, your meeting moderator. I'm here with Candy Pickard from the National Down Syndrome Society here in the studio. After such a rich and important morning discussion around what it is to be at risk of and living with DSAD, we're looking forward to the discussion this afternoon of understanding your treatment experiences and what you want from future treatments. But before we get into that, I'm going to hand it over to Candy to introduce our afternoon clinical speaker. Candy.
Thank you, James. I'd now like to welcome Dr. Michael Raffi, who will provide us with an overview of the current treatments of DSAD. Dr. Michael Raffi is the medical director of the Epstein Family Alzheimer's Therapeutic Research Institute and professor of clinical neurology at the University of Southern California's Keck School of Medicine. He earned his MD and PhD from Brown University and trained in neurodegenerative diseases at UC San Diego. Dr. Raffi is recognized internationally for advancing Alzheimer's disease therapeutics, particularly in individuals with Down syndrome. He serves as principal investigator of the NIH-funded ACTCDS and led the Down syndrome biomarker initiative, demonstrating parallels between Down syndrome-associated and other forms of Alzheimer's disease. He also oversees clinical trial safeties for the Alzheimer's clinical trial consortiums and holds leadership roles in multiple Alzheimer's research networks. And with that, I'll pass this over to you, Dr. Raffi.
Thank you so much. I will be giving you an overview of the current landscape for Down syndrome-related Alzheimer's disease treatments. These are my disclosures. So currently we have FDA-approved treatments that have been around for almost 30 years now, the cholinesterase inhibitors, that have been a mainstay for the treatment of dementia due to Alzheimer's disease for the general population. And what this slide shows you is that there have been several studies looking at this treatment in people with Down syndrome. And I draw your attention to the number of participants in each of these studies. These are very small numbers. And in fact, none of them reaches the threshold to make clinical recommendations in support of these treatments in people with Down syndrome. Now, as you know, people with Down syndrome have a very high risk of developing Alzheimer's disease dementia. And on this slide on the left, you can see the imaging of amyloid plaques in the brain. On the x-axis is age, and on the y-axis is the amount of amyloid in the brain. And you see there's a dashed red line. This is the threshold where we say a person has, above this line, elevated brain amyloid, and below this line, a not elevated brain amyloid. And you can see that around the ages of 30 to 40, most of the individuals are in blue. Those are individuals who are below the threshold of elevated brain amyloid. But those individuals on the right, above the age of 35, you can see many of them are colored red. They are above the threshold for elevated brain amyloid. They have the presence of amyloid plaques, again, starting around the age of 35 to 40. And on the right, you can see a graph that shows, again, on the x-axis at the bottom is age, and the y-axis is the frequency. This is the presence of the dementia diagnosis. So people who show the symptoms of dementia, trouble with thinking and trouble with carrying out daily activities. And you can see that the average age where people are diagnosed in the Down syndrome community with Alzheimer's disease dementia is about 55 years of age. 55 years of age. Of course, there is a spread here, but around 55. But I just showed you that on the left, amyloid plaques are present in the brain beginning around age 35. And so this gives us a window of opportunity between the ages of 35 and 55 to intervene against amyloid to try to reduce the progression towards the symptoms of dementia. We have established a consortium of clinical trial sites around the world that are conducting clinical trials specifically designed for people with Down syndrome and specifically targeting Alzheimer's disease. Our first study is the clinical trial-ready cohort for Down syndrome. This is a group of individuals with Down syndrome, 25 years and older, who are interested in getting involved in clinical research. We also allow co-enrollment in a very large observational study called the Alzheimer's Biomarker Consortium for Down syndrome. Essentially, these individuals come to the clinical trial site, they get to see the facility, they get to meet the staff, and they participate in memory testing, blood tests, and MRIs. And should they be found to be eligible for a clinical trial, will be offered one of several clinical trials. Once they complete that clinical trial, they may return back to this trial-ready cohort to participate in future research opportunities. We now have several clinical trials that are either ongoing or soon to launch that are targeting Alzheimer's disease in people with Down syndrome. One of the trials, the ABATE trial, uses an active immunotherapy to target amyloid. Another trial uses a monoclonal antibody called donanemab that is FDA approved and in clinical use now for the general population, and we're hoping with the Aladdin study to see if it works as well in people with Down syndrome. And a study launching soon called the APPLAUDS trial, which targets the genetic basis of Alzheimer's disease in people with Down syndrome by targeting the APP gene. There have been several clinical trials conducted that target amyloid, which we believe is the underlying cause of Alzheimer's disease, both in the general population, but also in the genetic forms, including those with autosomal dominant and Down syndrome-related AD. There are several studies, but you can see they are all fairly early-stage studies. Now, in terms of clinical trials and engaging with the Down syndrome population, there are several challenges, one of which is recruitment. We have a limited eligible population despite a high prevalence. There is heavy reliance and dependence on caregivers to bring our participants to the sites and to actively participate in the studies. And there's a geographic dispersion of the participants, yet a limited number of clinical trial sites around the world. There are also operational challenges. As I mentioned, there are a limited number of sites around the world that have experience in conducting Alzheimer's clinical trials, but also engaging with and supporting people with Down syndrome as they come into the research space. There is a need for specialized staff and training. And as with most Alzheimer's clinical trials, these are complex multi-procedure protocols that require expertise in their conduct and interpretation. In addition, there is participant burden. Individuals with Down syndrome who volunteer in clinical trials need to be comfortable with participating in MRI scans, PET scans, blood draws, and in some studies, lumbar punctures or spinal taps. There can be anxiety and behavioral challenges, and our main aim is to make all of our clinical trial sites a safe and comfortable environment for people with Down syndrome and their families. And we risk individuals dropping out or deviating from the protocol and unable to fully participate in these studies. A few years ago, we established a Down syndrome research participant board. These individuals who are on this board include individuals who are in the ACTCDS research group, the ABCDS research group, and individuals from the Down syndrome community. We have 7 dyads. That is, we have individuals with Down syndrome and their family members who are part of this board. And we meet regularly to review study protocols, consent forms, and study documents to ensure that our clinical trials are designed for people with Down syndrome and their families with their needs in mind. In fact, we have now published an article in a peer-reviewed journal that includes people with Down syndrome and their family members as co-authors, giving recommendations on what are the best practices in conducting clinical trials that are supportive and engaging for people with Down syndrome. One of the results of this interaction has been the recommendation for sharing back results from clinical research with people with Down syndrome in language that they can understand. And so we are very happy that recently we've rolled out a brain health report that returns the results of MRI scans, PET scans, and blood tests to individuals with Down syndrome and their families who are participating in our clinical studies. So in summary, people with Down syndrome develop a genetic form of Alzheimer's disease. Studies have shown that Down syndrome-related Alzheimer's disease is nearly identical to all other forms of Alzheimer's disease. ACTCDS is a consortium that is providing the infrastructure to conduct specialized trials for people with Down syndrome. We are now launching Vanguard sites that will help us develop best practices for clinical trials targeting Alzheimer's disease in this population, and an ambassador program with people with Down syndrome who are trained to engage with their community and help educate and raise awareness in their own community about research opportunities. Finally, several clinical trials of disease-modifying treatments are now underway or planned for adults with Down syndrome. Of course, this work takes a lot of effort, and a lot of individuals are involved, including those at the Alzheimer's Clinical Trials Consortium, and also the Alzheimer's Biomarker Consortium for Down syndrome, the advocacy groups, the NIH, and of course, participants and families who are involved in research activities. Thank you very much.
Thank you so much, Dr. Rafi, for that overview of the treatment landscape in DSAD and also covering so many of both the challenges and opportunities for conducting clinical trials with people living with DSAD. At this point, we're going to move into our second topic of the day, our second opportunity to hear the voices of this community as we now shift into talking about current approaches to DSAD treatment. When we talk about treatments in the context of this meeting, we're really casting a wide net. We want to, of course, are talking about treatments that are approved for treating Alzheimer's disease, as well as any treatments for individual symptoms, whether on-label or off-label. But we also are referring to other kinds of therapies that might be employed, as well as any strategies, even things like diet, exercise, or lifestyle modifications, anything that might be employed to try to make either living with DSAD a little bit easier, but also to help prevent the onset of symptoms of DSAD for those who are at risk. So within that context, we would like to know what you are currently doing to manage you or your loved one's DSAD symptoms or to help prevent the onset of those symptoms. We want to know how well those different treatment strategies are either treating the most significant symptoms or health effects of you or your loved one's DSAD. We'd like to know on the other side of things, what are the most significant downsides of those different current treatment approaches, and how do the downsides, whether that's a side effect, the burden of keeping up with a particular treatment regimen, or whatever that might be for you, how do they affect your daily life? Once we've spent some time exploring the current treatment landscape, we'll shift gears to looking towards the future and want to know, have you weigh in on what you're looking for from future treatments? While we all would love for a cure, a complete cure for DSAD, for today what we want to know is what specific things short of that complete cure would you look for in an ideal future treatment for DSAD? And along the same lines, as we're on that path to getting those treatments, what factors would be important to you in deciding whether to participate in a new research trial? To get us started on this topic, it's my pleasure to introduce our second panel of the day. We have Jane, Dee, Christine, and Diane, Christy, and Aaron and Andrew. Jane, why don't you kick us off and take it away?
I'm Jane from Seagirt, New Jersey. My sister Ellen was born with Down syndrome in 1965. She died in 2018 at age 52 of end-stage Alzheimer's disease. After our parents died, Ellen and I lived together. I was her primary caregiver and legal guardian. After 2 years of seeking answers for worrying symptoms, Ellen was diagnosed with AD in 2018. Only 10 years ago, when it was hard to find medical professionals who knew much about AD and Downs, or even what to do. When Ellen was born, a pediatrician gave our parents advice that was radical in 1965. He said, "Take her home and love her." He might as well have said, "Take her home and you'll see what love is." He said her life expectancy would be about 20 years. In fact, she was in the first Downs generation to crush that expectation. She was also in the first wave to face the onset of Alzheimer's in their 40s. Ellen was generally healthy. Graves' disease was treated successfully. She took Synthroid for about 30 years. Her cardiologist only ever needed to prescribe simvastatin. She had regular primary, dental, and podiatry care. For over 20 years, she was a research subject in a study directed by Columbia University's Dr. Nicole Schupf on menstruation and aging in Downs women. She had a great life, graduated high school at 21, employed for 20 years, and then on to a day program for the next 10. She was a 30-year Special Olympian in 8 sports. She had an enviable social life and circle of friends. The list goes on. Her life was full. She loved it. And then it all changed. Subtly at first, beginning around 2013. She had been meticulous, caring for her room and her things. She began to be disorganized and lose them. She needed prompts for routines that had been second nature, like taking her morning pills. One incident haunts me as a mile marker. She forgot how to dispose of a sanitary napkin in the trash can. She flushed it down the toilet. There was a flood, but more importantly, she had forgotten what to do. She had always been pleasant, cooperative, eager. Now she refused to do things like take her seat on the van. By 2016, her refusal behaviors became so extreme that she could not participate in the programs she once loved. One day, in a brief moment of clarity, she pounded her fists on our kitchen table and cried, "I hate this." Ellen suffered greatly from Alzheimer's disease. She became severely impaired, depth perception, language, senses. She would scream "no" at the top of her lungs, flail, and strike out, especially around showering. Declines continued: incontinence, loss of speech and mobility, seizures. A nurse who knew emergency room seizure protocols cautioned not to be quick to rush to the ER for a seizure. She had seen some with Downs and AD react differently and poorly to standard treatment. Early on, doctors prescribed Aricept and Namenda. After a year, neither showed any benefit and were discontinued. An SSRI was ordered for depression. Later, Seroquel and then risperidone were tried for agitation. They made it worse and were stopped. Ativan calmed her and was continued on hospice at home. Morphine provided comfort and peace at the end. An occupational therapist, a professor at Jefferson University, offered the most helpful and effective support. Her brilliant, practical approach focused on quality of life. Less is more. Don't fight with dementia. No doesn't mean no, were the mantras. She understood living with AD. She offered problem-solving strategies to daily challenges. She explained what worked yesterday may not work today, so pivot. Meet Ellen wherever she is. This improved Ellen's quality of life, and yes, the quality of her death. When I received Ellen's death certificate, the cause of death read Down syndrome. I insisted on an amended death certificate, not only to memorialize her suffering from AD, but to add a data point to the emerging critical story of Downs and Alzheimer's. My hope was that researchers and agencies such as the FDA will take notice and take action, and I sincerely hope that you will. Thank you.
Hi, my name is Dee, and I'm Susie's mom. We live in St. Louis, Missouri. Susie is 38 years old and has Down syndrome. She is an incredible person. She has a job, a cell phone, and a very active social life. Susie lives in a wonderful residential home where she has close friends and caring, supportive staff. Over the years, Susie has participated in research studies at Washington University focused on understanding how Alzheimer's disease develops in adults with Down syndrome. Susie has completed cognitive testing, blood work, PET scans, CT scans, and even 2 lumbar punctures. Susie truly enjoys being part of these studies. She appreciates all the extra attention, and she especially loves to share that she makes money from participating. Her dad and I have also taken part in the caregiver portion of the studies. The good news is that so far, Susie's scans show no signs of Alzheimer's. We've been told that the changes start to appear 10 years before symptoms begin, so we remain hopeful for many good years ahead. Susie has lived in her current home for 16 years. The residence includes 16 individuals, and over the past year, 3 of those individuals with Down syndrome have had to move out because they could no longer care for themselves or participate in daily activities. Before the transition, the facility made many adaptations. They did picture charts, they reduced activities, and even increased staff. Unfortunately, none of those measures were enough. Susie has felt the loss of these individuals deeply, as they were part of her family. We've stayed in touch with some of the families, and the strain has been significant. Siblings have had to leave their jobs and modify their homes to help aging parents care for their loved ones. One mother shared something that has really stayed with me. She said, "Megan has lost her spark." This young woman, once full of life and energy, is now in her mid-40s, rarely able to be left alone, and has little interest in activities that she once really loved. Right now, Susie's very independent. She gives herself a weekly GLP-1 injection, does her own laundry, sets her alarm to get to work on time, and regularly texts and calls friends and family to stay in touch. Her dad and I feel incredibly fortunate to be able to travel and remain socially active, knowing that Susie is equally engaged and happy. At the same time, we worry about the future. As we age, we may not be able to care for her in the same way. Our hope is that Susie can continue to live a long, independent life without the devastating effects of Alzheimer's disease. Susie's father is a physician who reads extensively about Down syndrome and Alzheimer's. We strongly believe that keeping Susie active, physically, socially, and mentally, may help delay cognitive decline. She exercises daily, sees her doctor regularly, works to maintain a healthy weight, and uses a CPAP machine. We hope these efforts will make a difference. Susie is deeply loved by her siblings, nieces, nephew, and many cousins. We recently returned from a family Disney cruise, and she loved every minute of it. We want to continue creating these memories together and have many more family trips in the future. Most of all, we want Susie to grow old with us. We would welcome any treatments or medications that could help if or when Susie begins her Alzheimer's journey. Keeping her actively engaged with our large, loving family is incredibly important to us. Susie's sister is a pediatric endocrinologist and sees some young children with Down syndrome. While those parents have many current needs, she also is able to share Susie's many successes, but our concerns about the future. My own dad passed away from Alzheimer's a few years ago. Watching this charming, intelligent man slowly fade was heartbreaking. My dad loved Susie, and I know he would never want her to experience the same suffering and decline that he did. That is why we are committed to doing everything we can to ensure Susie's life remains long, meaningful, and full of joy.
My name is Christine. I am 49 years old from Illinois, and I have Down syndrome.
I'm Diane, and I'm Christine's mother.
I have not yet been affected by Alzheimer's. I am keeping myself very busy every day to stay healthy by riding the Peloton bike, Tai Chi, play board games. I recognize Zoom activities with friends, baking, scavenger hunts, and best of all, we dance every day. I volunteer many days a week at the church to keep busy too. I have a doctor who is specialist in Down syndrome to help me stay healthy. When my family, we are looking for every way for me not to get Alzheimer's. I participated in the Life DSR research study for 3 years. I hope that by being in studies, something will be found to slow or stop our memory loss that comes with Alzheimer's. I know all about Alzheimer's because way too many of my friends have died from Alzheimer's. And even more of my friends have it now. My best friend for 30 years is at the end stage. I have spent time with her over the past 3 years and see how Alzheimer's has affected her and her family.
We were both independent, living, working, traveling, flying back and forth from Chicago to Syracuse by ourselves. And now the best we get to do is smile at each other and hug.
We've always been aware that our children with Down syndrome would most likely be diagnosed with Alzheimer's. We are very focused on prevention and early detection at this point, as Christine has not shown active symptoms. We have followed studies in the general population for a cure, and at the very least, a way to alleviate the devastating symptoms. For our children, starting earlier in their lives, before the onset of symptoms, is what we are looking for. With the high percentage of adults with Down syndrome population being diagnosed with Alzheimer's, we are looking for answers. Our concern for now, if Christine were to receive the diagnosis, is what will be available to us to manage the best life, to maintain her personality, ability to communicate, and enjoy her favorite activities. For the past 10 years, we have traveled the journey with so many friends. We are here to find out what we can do to not only help ourselves and our friends, but also those in the younger generation.
Hello, my name is Christy. I live in Southern California, and I'm the mother of Benjamin, a 32-year-old man with Down syndrome. He's the older of our two sons. My husband and I have worked hard to not let Down syndrome be what defines Benjamin. That said, who Benjamin is enriches our world in ways we never expected. Benjamin has lived in his own apartment with a support roommate for 6 years. He loves music, sports, dance, acting, and history. Benjamin has held various jobs in the community and has a knack for staying very organized, neat, and tidy. Despite early health issues, Benjamin has thrived. But staying healthy and working with healthcare professionals has always been a challenge. As parents, we found ourselves doing lots of homework with other families and sharing our knowledge with our care professionals. In Benjamin's early years, there was insufficient research in Down syndrome. Behavior traits and causes, neurology, learning acquisition, and other areas remained blank pages in the how-to book of raising a child with Down syndrome. Medical guidelines were simplistic. Anytime we heard that a psychologist or scientist was going to do a study, we would sign up. These studies usually lacked the funding to be very sophisticated or well-developed, but results began to create a foundation for researchers to continue asking the right questions. The link between Alzheimer's disease and Down syndrome started to appear frequently at conferences we attended. It would be years before there would be concrete information, but the gathering of data had begun. We knew that the answers had to come from us and families like ours being willing to participate in clinical studies. There was one memorable drug trial with Benjamin as a 14-year-old in 2008. Pfizer wanted to know if the drug Aricept would enhance memory retention in teenagers with Down syndrome. We participated, and then the study was terminated early due to insufficient support for the hypothesis in the early results. But it was during that trial that Benjamin gained some ease with the clinical setting, and so in this regard, the study was of benefit to us. Before the Aricept trial, he was frightened and tactily defensive when it came to blood draws. This procedure, while routine for others, took the assistance of 3 technicians to complete. However, with each study visit and the gentle reassurance of the research team, Benjamin learned how to get a blood draw with no assistance. He also became an expert at swallowing pills, but we discovered during the open-label portion of the study that Benjamin could not tolerate Aricept at the dose given. A research study called the Alzheimer's Biomarker Consortium for Down Syndrome, ABCDS, opened a few years ago for individuals with Down syndrome age 25 and older. Benjamin qualified to participate, and I am a co-reporter. ABCDS is a longitudinal observational study consisting of a 2-day appointment once every 16 months. We are 2 rounds in. During the visit, Benjamin undergoes cognitive testing and neurologic exam, blood draw, MRI, PET scan, and a lifestyle study. There also is a lumbar puncture procedure, which my son has not consented to in the first 2 rounds. As he grows more comfortable with this process and hears from friends who have done it, I'm hoping he will consent as well. The research team is very professional and the data collection is rigorous. Let me clarify what I mean by very professional. In my book, this means they go at Benjamin's pace, give him time, talk to him, and respect him as a person whose life is important. Benjamin can feel this. That isn't always the case in other settings when he has to remind someone, hello, I'm in the room, when someone is talking about him but not including him. Now, with the availability of concrete information becoming known through trials about DSAD and the lived experience of friends who are 10 to 20 years older than Benjamin, I see the inevitable reality. The prospects are scary. One friend tearfully told us that his best friend growing up no longer recognizes him. Friends slightly older are beginning to decline in their mental and physical abilities. Benjamin wants to enjoy the present. I do not want to ignore the reality of what is coming. I look at ways to make sure Benjamin has the best chance of maintaining his health mentally, emotionally, and physically to keep his advantages high and perhaps delay or negate the development of DSAD. My hope is that treatment options will expand. How may our family and our friends help make new treatments a reality? Many families like mine are committed, and we are experienced at breaking barriers.
Hello, my name is Erin Sulman, and I'm here with my brother,
Hello, my name is Andrew.
and we live in St. Louis, Missouri. Not only am I a sibling to a person with Down syndrome, I'm also the executive director of the Gateway Down Syndrome Association, which is one of the larger Down syndrome associations in the country. We're here today to tell our story, and that story is that Andrew was recently diagnosed with the early pathological signs of Alzheimer's disease. To date, we have not noticed any behavioral signs of his decline. However, his brain is objectively showing the buildup of amyloid proteins. We know this because of his participation in the ABCDS research taking place at Washington University here in St. Louis. Andrew volunteered for the ABCDS study to understand how Down syndrome and Alzheimer's disease interconnect and to improve the lives of people with Down syndrome in the future. I am also involved in that trial as a sibling control. Andrew is an amazing human. He has absolutely changed my life and the lives of everyone he knows for the better. He has participated in Special Olympics, has worked since he graduated high school, and is currently still employed. In fact, the coffee roasting company where he works gave him a raise soon after he started because he was so efficient and productive at his job. Isn't that right?
Yeah, that's right. And
The discovery of this disease affecting my brother started last year. Through the ABCDS study, Andrew began participating in cognitive tests, MRIs, PET scans, and more. And after 18 months of participation, the researchers let us know that the buildup in Andrew's brain had increased to the point where he could participate in clinical trials. That meant that Andrew was eligible for the HERO clinical trial to try and slow the progression of AD in people with Down syndrome. When we received this news, of course, we were very surprised and concerned. As a family member of a person with Down syndrome, this news is almost inevitable. However, it's never easy to hear, especially when your loved one is not yet even 40 years old. When we found out about the trial possibility, we all talked as a family, including with Andrew, of course, and the researchers in the clinical trial about the risks. And the doctors were phenomenal in helping him understand the risks versus the benefits, and they made it so easy for us to understand how the trial would go and what we could be anticipating. We were not very concerned about the risks because the mechanism by which the drug would be administered in this particular trial was also used in other clinical trials successfully, and that mechanism in this case is a lumbar puncture. But we were actually really hopeful because we knew through this study he would undoubtedly get the medication, unlike if he had participated in a double-blind study. Andrew kept saying he wanted to participate because he wanted to help other people with Down syndrome and kids with Down syndrome in the future. He began the clinical trial in the middle of 2025. He underwent numerous clinical visits and 3 lumbar punctures. The team was absolutely phenomenal, but he did have to take off work and skip participating in his favorite activities to receive the uncomfortable procedures. He had to stay in the hospital overnight, and he had to go to many clinical visits. But he never gave up. He wanted to see this trial to the end, not only to help himself, but others. And after all of this involvement, the HERO study was canceled in February of 2026 without warning by the pharmaceutical company. And we were told it was because there were not enough participants. Andrew was the first and only person with Down syndrome to enroll and participate in the HERO clinical trial. Unfortunately, because the trial was stopped in the middle, he is now left with no further follow-up and no hope for information about how the medicine may impact the trajectory of his life. I feel his contribution was underappreciated by the pharmaceutical company and the Down syndrome research community at large. We're hoping that Andrew can get re-enrolled in ABCDS, but we're unsure if that's possible, so we may just be left to wait. It's scary and sad that people with Down syndrome have been left out of clinical trials for so long due to their disability. I understand the need for additional safety and concern with this vulnerable population, but they too have the right to access potentially life-changing therapeutics. Through my job, I witnessed the decline of my friends with Down syndrome and the devastation caused to families. We want to have hope that in the future, not every person with Down syndrome will be affected by Alzheimer's disease. We're asking for sensitivity in this community and acknowledgement that people with Down syndrome have self-determination. They are valuable contributors to research and deserve fair and equitable treatment in study participation, study recruitment, and follow-up. My brother is a wonderful, caring human who decided to participate in the study because he wanted to help others. He wanted to help children with Down syndrome who might develop Alzheimer's disease one day. Those are his words, and we should all care as much as he does. Thank you for your time and for listening to our story.
Thank you, Aaron and Andrew, and to all of our panelists this afternoon in helping us get started in this discussion of understanding you're navigating the current treatment landscape as well as clinical trials. So now we have the opportunity for the second time today to invite all of you in our live audience, people living with Down syndrome, as well as their care partners, into the conversation. If you'd like to call in and share some of your treatment experiences, we welcome you to do so now and throughout the afternoon by dialing 1-703-844-3231. Again, that's 1-703-844-3231. If you call in, you'll get connected with our operator. We'll be able to put you into our queue for me to be able to bring you then into the conversation. So please call in, and we'd love to welcome you into the program. But to get us started on this topic, as we're exploring current treatment approaches, we would like to start with a few polling questions to get a sense of our experiences. And so if you can, this is for our individuals living with Down syndrome and care partners only, go to www.pollev.com/DSAD-PFDD. Again, that's pollev.com/DSAD-PFDD. You can keep this webpage up on your computer, on your phone for the whole afternoon. As we go to different questions throughout the discussion, they will automatically appear. All you need to do is click down the response options, and they'll be automatically submitted. There's no submit button you need to look for. Here, our first question for the afternoon is we want to know that so you may want to have someone help you with these as well. I mentioned as some of these may be complex, so feel free to answer as a family. But the question here is, what medications have you taken to treat symptoms associated with DSAD? And you can select all that apply. The options here are A, traditional Alzheimer's treatments, or traditional Alzheimer's disease medications, B, anti-amyloid medications, C, antipsychotic medications, D, anxiety or depression medications, E, anti-seizure medications, F, sleep-related medications, G, pain medications, H, an investigational medicine in a clinical trial, I, some other medication not listed here on the slide, J, you tried to get medications, but were not allowed to have them, K, not applicable because you have not used medications, or L, if you're not sure whether your loved one or you have used medications to treat symptoms associated with DSAD. Give everyone here a few moments. Just a reminder, when we see polling questions that allow the selection of more than one option, as is the case here, select all that apply. The percentages we're seeing are percentage of total responses, not the percentage of people making a particular response. So you can kind of view the red bars as a bit of a relative ranking. So not surprising, from the morning we had quite a large participation from individuals at risk for DSAD. So we see that the largest response here is not applicable. I have not used medications, although certainly if you're someone that is living with DSAD or a care partner and you have not used medications, we are very interested in hearing your experiences. But for those who have used medications, it looks like some of the top medication uses for anxiety and depression, for seizures, and antipsychotics being the top three. After that, we do see traditional Alzheimer's medications and sleep-related meds. Everything here, no one reporting use of an investigational medicine in a clinical trial, but certainly a number of other medications that we didn't list. We do see that there are some people reporting that they tried to get medications, but were not allowed to have them. If we go to our next polling question. So here, we'd like to now go and talk about things besides medicines. So besides medicines, what other things have you done to help prevent or manage the symptoms of DSAD? And you can select all that apply. So the options here are A, physical therapy exercises, B, occupational therapy exercises, C, speech therapy, D, behavioral therapy, E, you made changes to your routines, F, you changed where you live, G, gotten more help from caregivers, H, focused on exercising regularly, I, worked on puzzles and memory exercises, J, changed your diet, K, something else that's not listed here that you've done to try to help prevent or manage the symptoms of DSAD, or L, not applicable, you're not using any of these strategies to try to prevent or manage symptoms. Again, we'll give our audience here a chance to submit their responses. And as you can see, we are casting this wide net of different things. We want to hear about your experience trying these different things. So if you're some of the top things that people are trying, both for prevention and treatment, are getting more help from caregivers, focusing more on exercising more regularly, changing routines, changing where they live, changing their diet. After that, we kind of see physical therapy, as well as puzzles and memory exercises. A lot of different things that are being employed by this community, and we would like to unpack your experiences. What's worked, what hasn't, what are some of the downsides? But to get us thinking a little bit more about that, we have one more polling question here to kick us off. And so here I want you to think about all of those things that you've used or tried in the past, and we want to know, do you think that those medicines and changes are making you feel better? Or for our care partners, do you think that they're making your loved one feel better? And that's based personally off of what your treatment goals were, and that could be prevention or treatment. The options are A, no, not at all, B, very little, C, somewhat, D, yes, very much, or E, not applicable because you're not using anything. So as you're making this selection, I want you to think about what it is. Though this is, all the questions are personal and subjective, but we want to know, for those of you who are selecting somewhat, which seems to be our leading response right now, things are helping somewhat. What came to mind? What have you tried that has been helpful, and what did that look like for you or your loved one? It looks like about a fifth of people are saying both, very little. So same for you. What little bit has helped, and for those of you that say no, not at all, same thing. What have you tried? What has not worked? Nobody, importantly, I should note, is saying that yes, medications and these other changes have helped very much. And then, of course, a number of people saying that they're not using anything. So thank you for participating in polling. Again, you can keep that Poll Everywhere page up. We'll be coming back to some polling questions here in a little bit. But I'd like to now welcome our Zoom panel here, some of your peers from within the community who will be sharing their perspectives throughout the discussion. So Joe, maybe we can start with you. As you were looking at those long lists of different medicines and then other kind of treatment and management strategies, I'd like to maybe start with the things that have been the most helpful, if at all. So is there anything that comes to mind for you that fits into that category?
Yes, I'm Joe Niemeyer in St. Louis, Missouri, and my son is 26 years old and has Down syndrome. He's an awesome kid. Through one of our studies, we've found out that he had sleep apnea, so we had him on a CPAP, and that was a big help on getting him a good quality sleep at night.
Sure. And so how long has he been on CPAP? As how's...
It's going on a year and a half.
Yeah. And, I guess, in making that treatment decision, how... what was he experiencing, that led to you seeking that treatment? Can you just kind of tell us a little bit of what he was going through?
He'd sleep a lot and he'd wake up tired. And I think the CPAP has helped him get a solid night's sleep and helped him fall asleep deeper and quicker. So yeah, he, had his first week or so, he had adjustments to it, but other than that, he's done very well with it. And so now he takes fewer naps throughout the day, and he has more energy, it seems like.
Gotcha. Well, thank you so much, Joe, for getting us kicked off here, thinking about things that have been most helpful. Nancy, I'd like to bring you into the conversation, thinking about whether it's, prevention or treatment of DSAD, what maybe has been most helpful in your experience.
Sure. My name is Nancy Murray. My husband and children and I live in Bethel Park, Pennsylvania, which is a suburb of Pittsburgh. We have 3 adult children, all of whom have Down syndrome. And our one son, James, was diagnosed about 2 years ago. He's now 57. And it's been a pretty steady decline that we've seen in him. What we're doing right now, and it's successful. Really watching his nutrition, making sure that he's eating whole grains and a lot of protein, fruits and vegetables, limiting all those foods that all of us need to stay away from. The other thing is we're working with a behaviorist.
Okay.
And she started James on puzzles, a lot of brain health games. Thank goodness he's not resistant to any of these games so far. He is resistant to a lot of other things in life right now, but not to the puzzles and the games. And we found that this is something that he enjoys. He also lives in a community home with a young man that they've grown up together. They've known each other for about 40 some years. And we know that being social, continuing all of the activities that James and David have been involved with, for years, is very important. Even though we are seeing that more and more now, he's declining to go out very much and participate.
And so you mentioned that, kind of the dietary changes, the nutrition approach, as well as the, kind of introduction of the memory games and puzzles have helped. How would you describe how they have helped James?
Well, James had been putting on weight the last couple of years. So believe it or not, he did a very good job before this all started. He lost about 60 pounds. And that was a godsend because, once he lost the weight, Then he was diagnosed with, early dementia. So he was accustomed to that, menu, if you will, and the nutritional, diet that we had him on. So that's been very good. And as I said, about a year ago, the behaviorist started, with the puzzles, the games. The staff at the community home have been excellent. I think the other thing worth mentioning is we spend a lot of time providing the staff with educational resources, many from NDSS, so that they feel very, very confident in their abilities to, help him through some of the behavioral outbursts that, he's starting to exhibit.
Sure. And maybe now understanding a little bit of what he's going through in terms of his DSAD symptoms too, do you feel that the memory games and puzzles have helped? Have they improved anything, or do you feel like it's more of like maintaining what he has?
Yeah, unfortunately, I wouldn't say they're improving, but he's maintaining skills, and he's enjoying them. They have given him another source of enjoyment in his days.
Sure. And, in terms of, the behaviorals and outbursts, I think you mentioned, has there, any of the treatments that you've mentioned, none of those have been useful for that particular symptom? Is that, or do you feel that, kind of the social engagements, staying involved has been, beneficial on that front?
No, a couple of other things worth mentioning. Our PCP, our primary care physician, recently put him on an anti-anxiety medication, which we believe it's pretty recent, but we're beginning to see where it's working. And the other thing is, whether it's us or the staff, engaging in a lot of redirective activities, so that when we see that he's starting to get upset over something, starting to be resistant to doing something, we start redirecting as soon as we can.
Right. And I know it's early in the anti-anxiety medication journey there, but you are starting to see some signs that that's helping. Can you give an example of how you've noticed that?
Well, the other thing is there are no side effects from the anti-anxiety medication, so that's number one. And we just see that he's more calm. Where a couple of months ago, even there were more episodes where he was maybe raising his voice, yelling at somebody, and now he's just more calm.
Sure. Well, thank you. That's very helpful to hear. Thank you for sharing those. Amy, I'd like to bring you into the conversation here as well, as we're kind of think about different treatment approaches, anything that kind of stands out as being most helpful.
Sure. My name's Amy. I'm from Weed, California, and my daughter Kate, who is 45, has a diagnosis of Down syndrome-related Alzheimer's disease. She's very early in her symptoms, or well, sort of moving on. But she has quite a large load of amyloid, according to her blood tests and her PET scans. So she's on quite a cocktail of medications, which I was very initially resistant to having that many medications. She's been on thyroid medication and estrogen for several years, but the first medication added was Depakote because she started exhibiting some symptoms of small seizures with just mild myoclonic twitching. So the Depakote was added. I can't say we noticed anything really significant after the addition of Depakote. But then they added a nighttime medication called Prazosin, which was specific to her waking at nighttime and having kind of night terrors. And that particular medication made a huge difference in her ability to sleep through the night. and not be awakened with these kind of nightmares. Then they added Prozac, a small dose of Prozac for anxiety. And finally, we just added a small dose of Seroquel. And that seems to have made a huge difference in her, like Nancy was saying, she started having these outbursts where she was argumentative with her staff and really angry and walking around the house, tearing up paper and cursing about having Alzheimer's. And she would shred paper and leave it all over the house. And adding the Seroquel has really calmed that anxiety down. But in addition to that, she is still verbal. So she has a counselor that she sees twice a month. And it's great because the counselor knows she's not there to fix something or cure anything. She's there to help give Kate strategies to get from this week to the next appointment without having major meltdowns or anxiety. So they always focus on a strategy for the next 2 weeks. And that's been really helpful as well. Finally, well, 2 more things. We use a lot of the visual aids available through the Down syndrome resource page at Advocate Medical Health. Dr. Chacoin's organization has an amazing resource page for individuals with Down syndrome and caregivers. And we use a lot of their visual aids to help her get through the day. And then she kind of creates her own strategies. She comes up, 2 in particular that she came up with. One is she wanted Barbie dolls. And I kind of felt like, what are we doing going back to childhood? So I asked her, why do you want Barbie dolls? And she said, I can practice conversations. So of course I immediately ran out and bought Barbie dolls, and she sits in her room and has conversations back and forth with her Barbie dolls. And then she called a couple days later and said, oh, I also want a pretend phone. And I said, why? And she says, because I need to practice those conversations. So I said, well, you could just use your cell phone and call and pretend you're talking. And she says, Mom, I don't want to butt call anybody. So we bought her a pretend phone.
Yeah.
And so now you can hear her in her bedroom having conversations about everyday activities.
Yeah. Well, Amy, a lot to unpack there. I have a few things I want to follow up on. First is, you mentioned, treating the night terrors that were being experienced. Was that, how long, had, Kate been experiencing those, and what did it mean to kind of have relief from that? Like, how did that help her? Obviously it helped her sleep through the night, but what was the impact on her quality of life from that?
It was really disturbing to her to be having, she's never had issues with nightmares or not sleeping through the night, even though she does have very mild sleep apnea. She is CPAP non-compliant. She just pulls it off in the middle of the night. She doesn't even know what she's doing. So the waking up terrified was really bothering her. And so that went on for about 6 months. And then finally her neurologist suggested the small dose of the prazosin. And at first, actually, a psychiatrist prescribed a very large dose for, she's a tiny girl. She only weighs 111 pounds. Right. And they had her on what is a full adult dose.
Okay.
And it didn't seem to be making a difference. And she would wake up in the middle of the night and be groggy and dizzy.
Okay.
And when she finally saw the neurologist was shocked at the dosage and cut it back from 5 milligrams to 2.
Okay.
And that solved the entire issue.
Wow. And then, just in general, with this cocktail, you described a number of like tweaks and changes and additions, upping and lowering of doses, how from doctor's visit to doctor's visit, like were you and she thinking about her needs? Were there certain symptoms that were most troublesome that when you went to the doctor, you said we need help with this particular thing, and that's when adjustments were made? Just can you tell us a little bit about that? Like a little bit sounds like a bit of trial and error kind of approach to trying to address these symptoms.
Sure. Fortunately, Kate used to live independently. She lived independently for 15 years. And she now has staff who lives with her. So she lives in her own apartment with supported living staff. And fortunately, because the staff comes from a local agency, they are required to write daily notes and they are required to document symptoms and symptom changes. So we have a tremendous tracking capacity. And I can send messages back and forth with her neurologist, who's very, very responsive, and will call us in and say, well, I think we need to see her for this, or we need another blood test. So I've been incredibly fortunate to have found a really responsive and excellent neurologist who's monitoring all of her medications.
Wonderful. Well, thank you, Amy. I do see that we're getting a number of written comments that are coming in on this topic. So, Candy, you want to check in? What are we seeing there?
Absolutely. So we've heard from Kathleen from Minnesota. Kathleen states that my brother Larry was diagnosed with Alzheimer's in 2020. We noticed changes in his speech first and then his motor skills. We started him on Donanzapine, which helped with his motor skills. Also from Donald from Tucson, Arizona. Donald states that my sister was diagnosed with Alzheimer's in 2020, but was symptomatic as early as 2018. As her brother, medical guardian, full-time caregiver, I have been giving her a cocktail of nicotinamide riboside, omega-3, liquid turmeric, and magnesium L-threonate, with very closely weekly monitoring of her INR. Although her language loss is severe, I believe that the velocity of her decline is slowed substantially. And then also Catherine from Weed, California. Catherine states that I have a lot of pictures around the house to remind me to do chores and how to do things. The calendars help me remember when things are going to happen.
Great. Well, thank you everyone who's been writing in, sharing those experiences. Please keep those coming, and we'll be reading more out throughout the program. If we don't get to your comment, know that we did get it, and we'll be including it in the Voice of the Patient report. I want to broaden the discussion a little bit. We have certainly continue to invite things that have been helpful, but we know at the same time that treatments often come with different downsides. And so I want to go to a polling question on this topic. If you want to open up that webpage, www.pollev.com/DSAD PFDD. Here we want to understand, what don't you like about the medicine, or those different, changes and approaches that you've been made or been taking. And you can select up to the top things, 3 things that you don't like about your current treatments. So the options are A, I don't think they help me feel better at all. B, they help with some problems, but they don't fix all the things that make me feel different than I used to. C, they used to help me, but do not help me anymore. D, the medicine I take for DSAD symptoms interferes with medicines I take for other things. E, I don't like the medical procedures that I have to do. F, I don't like the side effects of the medicine. G, some other reason, so some other thing you don't like about your medicine and other treatment approaches that's not listed above. And H, not applicable because I'm not using anything. Again, this can, both for treatments approaches, both for preventing DSAD as well as treating the symptoms of it. What are some of the things that you and your loved ones don't like about the medications and other treatment approaches? As you're making these selections, I want you to think about why these are what experiences are you thinking of? What treatments, what strategies, that have had some of these downsides. So as it stands, it looks like the top most reported thing that the community here does not like about current treatments is that they help with some problems, but they don't fix all of the things that make them feel different than they used to. After that, it's pretty close. I mean, everything being selected relatively, highly, with the exception of nobody selecting that it interferes with medicines they take for other things, and a somewhat smaller group saying that they don't like medical procedures that they have to do. So still a wide range of different things that are kind of downside, some of the trade-offs from current treatments that exist today. So thank you for doing polling. If you would like to call in and share some of your experiences with these current treatments, including downsides, we invite you to do so. You can call in now at 1-703-844-3231. Again, that's 1-703-844-3231. We'd love to welcome you into the program. But to continue this discussion on current treatments, I'd like to come back to our Zoom panel here. And Michael, maybe we can start with you on this topic, thinking about the range of different things that's tried, maybe whether or not something has been helpful, have there been any important downsides to note?
Were you directing that question to me specifically?
Yes, just starting with you on this topic, if there's any current treatment experiences or past treatment experiences that you'd like to share.
I think I tend to look at this from thousands of feet up. In my opinion, treatment lies in the context of the overall beauty of a child and an adult's life as they pass through their life with Down syndrome. And I think their agency is incredibly important because it's important to them. And there are things that through their lifetime they love doing and are interested in learning and athletically enjoy thoroughly. And those things, I believe, are incredibly important for all of us to reward. Our daughter, Molly, was highly spirited and wanted to do things herself. She didn't want to be taken care of when she could do it herself. And that spirit was something that everybody loved. And it continued into her adult life where she loved to travel and interact with members of her family and her extended family, which included caretakers that she lived with for a number of years. And she actually learned to speak Spanish and understand Spanish to a degree in their home. I do think that medications helped in the final stages of her dementia because she became extremely anxious and unwilling to go to the doctor's office, unwilling to go in a car and so forth. And one of the very effective medications that worked was clonazepam for anxiety.
Okay.
But it was also a difficult drug because at times she refused to take her medications altogether. And she had a withdrawal seizure, I believe, from that medication. We wondered if she had hypoglycemia at the time because we were managing her diabetes fairly tightly. But no, she had blood sugar was normal, and it was just the withdrawal of that one medication that we believed was responsible for her seizure.
And that was, Michael, that was withdrawal because she was refusing to take it and she experienced withdrawal symptoms?
Yeah.
Wow.
And she, I think one of the things that I would like to share with everybody is what I think is the importance of the epigenetics of individuals with Down syndrome, because that will keep them away from the various problems that are fraught with everybody. And I can tell you diabetes was type 2 diabetes was a very difficult trip for her. She loved to eat. She wanted to eat what she wanted to eat, and it was always very difficult to temper enthusiasm for that.
Sure.
And I must say that the early management of diabetes was easier than the later management. The early management, she was exercising a lot, and she was able to control her weight a lot. But as we got deeper into her age, those things were not as effective.
Yeah.
And I think the things that are most important, I think, is nutrition or diet. I think relationships are extremely important. She was blessed throughout all her life. She had wonderful relationships and friendships, and she interacted socially in very intuitive and lovely ways, and that was always positive for her. I do think that she did suffer from anxiety and stress during much of her life. She actually was placed on medications at an earlier age before she had any effects of dementia.
Wow.
And this was difficult as well for my wife and me as parents to see her on any medications, but she had a disorder where she could not stop doing certain things, and that annoyed other people around her, and they wanted her on medications. And so medications, in my opinion, are a very difficult a proposition. Sometimes they're wonderful, sometimes they're not, and that will always be the case, in my opinion. There will be no free lunch, but you need these medications, for specific care.
Yeah. And Michael, it's not, I also hear in what you're saying, medication that is being driven by what is best for the person living with Down syndrome, and not necessarily just for what is useful to those around them. In terms of like some of the repetitive behaviors. Didn't want to lose that in what you were saying, but this has been really helpful. Thank you so much for sharing some of those treatment experiences. I want to bring Rosemary here into this conversation as well, just thinking about treatments, that wide net of things that count as treatments, any treatment experiences that you'd like to highlight or share.
Hello. My name is Rosemary. My daughter is Alicia. She'll be turning 36 soon. The problem with us is that we can't find doctors that will really take care of her. She was born with Down syndrome. A couple of years later, she had Dandy Walker, as they call it.
Mm-hmm.
She winded up having, only I say about a couple of months back, they diagnosed her with dementia. With dementia. And so the thing is my husband and I, we have worked in the medical field, especially me. Him was more in the military. But it's like we've seen parents that were taking care of children with disability
Mm-hmm.
that didn't really want to work with them. They would knock them out. They would get them medication, knock them out,
Right.
and they were useless.
Mm.
I saw a lot of that in the emergency room with the children.
Yeah.
She was a cheerleader in high school.
Mm.
She was in a dance team also. But then when she was getting ready to graduate, she quit talking
Mm.
and doesn't say anything. So um, I've been trying to get her to do sign language,
Mm-hmm.
but it's not helping in a world of her own.
Right.
Um,
Yeah.
so
No, Rosemary, that's
the thing is,
yeah, that's
the thing is with her, she can't take any medication because when she was born, they damaged her esophagus,
oh
so she
goodness.
can't swallow any pills.
Oh, that certainly is a completely additional, challenge on top of, all of the typical challenges. And, thank you for sharing, some of your experiences and, hearing, the challenges of, almost sedating, over medicating in a way as a way to treat symptoms being, not something that's helpful. So really appreciate you sharing there. I do see that we've been getting a number of written comments here, so I want to give voice to some of those who have been writing in. So,
Absolutely.
Candy?
I heard from Colleen from New York that managing end-stage symptoms was difficult, and most people do not know how to manage this as a caregiver. Colleen is. And then Vicky from Arizona stated that my daughter did not do well on the lowest dose of Donanza pills. So I took her off after the doctor's office said to give it at least a month. It made her symptoms much worse, and as soon as I took her off, she was back to more of her old self. And then there's one other comment that I would love to share is from Amy from California. And Amy states, because we live so far away from all the clinical trial centers, the time and expense of traveling to participate would be difficult, but worth it. It would be amazing if there were satellite research centers or even an opportunity for personal neurologists, physicians to opt into a trial.
Sure. Well, thank you for everyone sharing that, and please keep those coming because we're going to stay on this topic for a little bit longer. Talking about current treatments and some of the treatment downsides. Let's come check back in here with our Zoom panel. Amy, maybe we'll come to you as you shared some of the things that have been helpful. You saw the list of some of the treatment downsides and other trade-offs. Is there anything that comes to mind as something that was either least helpful in terms of the drug benefit or came with the biggest trade-off or downside?
That's a great question. We've been pretty fortunate, I think. Most of the medications that we've tried have been helpful to some extent. And like I said, we have a very responsive neurologist. So the only downside for us in managing all of this is that we do live in a very rural area.
Okay.
So our closest decent neurologist is 75 miles away. So fortunately, they have telehealth now, and that really helps. But the downside for Kate is that she just feels, and I think this is probably something that Michael also alluded to, she gets really tired of having to take so many pills every day. And she gets to the point where she is a little resistant with her staff. And if we've gotten to the point now, they used to be able to put them in a little cup and she'd just take them as she ate breakfast or dinner. And now they have to hand them to her one at a time to make sure she takes the medication, because I think she's up to 9 different pills a day. And she just hates being structured that way. And she keeps saying, I just wish I was normal again. So I think that they have a very keen sense that things are wrong, things are different, and they don't like it. And having to take so many medications is really frustrating for her.
Sure. And so you talked about how, and it used to be they could just all be in a little, cup. I mean, what, was it? Do you think it was just the addition of additional things that it hit a certain point there was just too many, or what do you think triggered that kind of switch of no longer being willing, or kind of, I think the term Michael used really resonated, was her agency.
I think it actually comes down to a lack of control.
Lack of control.
And they start feeling, at least she does, and I think this is fairly generalized for most of our loved ones who have Alzheimer's.
Mm-hmm.
The lack of being in control of their own lives, and the lack of being able to choose to take a medication or not.
Okay.
And having someone say, you must take this now. So really, it just comes down to stubbornness.
Sure. And do you think that is something that's related to the progression of the Alzheimer's, or is that something that you would have said even before Alzheimer's? If you tried to be too controlling, eventually you'd hit that stubbornness, as you put it.
Sure. I mean, sure. Stubbornness has served her well. Stubbornness allowed her to live independently. Stubbornness allowed her to navigate a metropolitan transit district. Stubbornness allowed her to do so many things that others would have said she couldn't do. But in terms of this is definitely related to the Alzheimer's. This side of her personality is very different. She's always been cooperative when she knows the end result is helpful.
Mm-hmm.
And if staff is being helpful, or if a parent is being helpful, she's always been very cooperative. So this level of stubbornness is very, very much related to the Alzheimer's.
Wow. Well, thank you for sharing that. Joe, I want to bring you in on this conversation, treatment downsides, whether that's on things that haven't been as helpful, or even if they have had some trade-off, what comes to mind for you?
I'm very fortunate in the sense that Joseph still is pretty young, 26.
Yeah.
And we're part of the study that at Washington University that I don't know if you saw that Aaron earlier mentioned that, some of the funding's been cut all of a sudden and stuff like that to affect some of this. But Joseph is active. He has a very, very great social activity. I don't think I can see, signs of Alzheimer's. I, saw my mom and stuff. And that's my concern, is I want to have him in this study. I want him to participate in, getting medication prior to it's too late, or it's after the fact, or it's so far down the road that, again, it's not going to get any worse. But by that time, I'd rather not get worse now than later.
Right.
And, one of the doctors that is doing the research, the eye-opening thing that really concerned me is him mentioning that, the 21st chromosome is one of the main chromosomes that creates the plaque, for the Alzheimer's. And by having that extra chromosome, the kids need to be extremely active to help kind of process and flush it out, and they're not. And that's my real concern. Like I say, right now he's active, but listening to these other participants share their view of seeing their children go through this and change their personalities and just health issues and everything else. That's concerning, and that's why we're in the study, and that's why right now I feel blessed in that he's like I said, he forgets a lot of things, and which I get fearful. So that's fortunately, like I say, we're ahead of the game and trying to participate in these studies to help him, but also eventually help others down the road. So when they cut the funding, it gets really discerning for the community.
Right.
To me.
Yeah, no, super helpful, Joe, and great to hear about, kind of thoughts on the importance of kind of having the opportunity to be proactive, both in terms of monitoring and treatments that are available. We do have a phone caller, so I would like to bring Jane from New Jersey into the conversation. She's the primary caregiver to her sister who passed away from DSAD. So, Jane, I would like to welcome you to the program. Are you with us?
I'm here. Hi there. Thanks for letting me join in.
Yeah, so would be very interested to hear any treatment experiences that you would like to share.
Well, I thinking about what were the most effective things that that were offered to my sister as her declines continued, and then ultimately she was at the end stage of Alzheimer's disease, which is horrible, heartbreaking. Sure. But frankly, when the pharmaceuticals failed for her, really, the one thing that really made her life and her death better than they might have been were the interventions that actually I was trained in from an occupational therapist. And these were interventions that were all about how to live on a daily basis and how to try to get through a day in the most peaceful way possible for her. And I became such a believer in the value of occupational therapy and working with an occupational therapist who just had a way of understanding and kind of training me for what to do when things got really difficult. So, for example, walking over a threshold into another room became a thing.
Okay.
And I was my awareness was raised about understanding what was happening in the environment. Like if you're walking into a bathroom with a white tile floor, that looks like an abyss. And so get some colored throw rugs to put on the floor so that my sister could actually now walk into the bathroom. And, these were all little solutions. These were problem-solving exercises that made a real difference in the quality of her life.
Wow. No, that's very helpful to hear. So can you, maybe share, because you originally mentioned that they were helpful, at some of the latest stages of her disease progression. Was that you weren't kind of put in touch with, didn't have that benefit of the occupational therapist until then, or was it just that she had not declined enough to really, benefit from those types of, occupational therapist interventions until she had progressed so much?
This is my sort of take on what was happening. And we lived between New York and Philadelphia, so it was a great advantage to be able to access some of the people who at that time really knew something about Down's and Alzheimer's disease. And what I originally thought were her behavioral issues turned out, I got a different understanding of them as the effects of Alzheimer's on her brain were causing her to, for example, there was a little van that picked her up every day to go to a day program. And the day came that we'd walk out of the house, the end of the driveway, to get on the van, and she would refuse to get on the van. And I thought, this is like behavioral, or did something terrible happen at the program and she didn't, and she was refusing to go. And it was actually the occupational therapist who helped me understand that what was happening was you'd walk to the end of the driveway and to the street, and the street was asphalt, blacktop. And she would see the blacktop, and then she would see the 3 steps that were black to get onto the van.
Right.
And she perceived that, because of Alzheimer's, the onset of Alzheimer's, as a black abyss that she was that she would fall into.
Wow.
And she was terrified of that. And if you understand it that way, you can understand what her experience was.
Right.
So there were some simple solutions to that, believe it or not. And it was, in that case, the solution was to get that black and orange safety tape and apply that to the steps.
Yep.
And create some color contrast so she could actually now navigate walking up the steps.
Right.
And so that's just an example of the way that you had to think about adapting to help her get through the day.
Yes. Wow. Well, Jane, thank you so much for calling in and sharing some of that. We had not heard much about occupational therapy yet, so definitely appreciate you sharing some of those successes from employing those. Before we move on from this topic, Nancy, want to give you a chance if you'd like to weigh in on any downsides, trade-offs, that you all have experienced.
I don't think this is a downside or a trade-off, but in listening to Jane, in addition to the loss of control that Amy spoke about. For our son, James, it's also the communication issues. He's lost a lot when it comes to his abilities to tell us what's going on.
Yep.
Sometimes he just looks at us. It's a blank stare, and it's you just don't know what he's thinking because he can't tell you. So that for us right now, that is a huge part of what we're dealing with. Just his inability now to tell us, how he's feeling. Is he afraid of something? Does something hurt? As Jane said, I don't want to get on the bus. It's not that I'm being resistant. It's not behavioral, but I'm afraid to get on the bus. He can't tell us that. So, that's not something any medication is really going to help with.
Right.
It's just something that, day to day, you try to figure out, okay, well, this happens at this time of the day, or this happens when this happens. So you kind of piece it together and, hope that you're putting A and B together and you're coming up with the right C. In terms of trade-offs, I think for us, because so many people with Down syndrome have, multiple medical issues, it's neurology, it's cardiology, it's rheumatology, that, a new medication might be prescribed to deal with anxiety.
Right.
But you also don't want it tipping the scale if the person has, as Joe said, diabetes, or as Michael said, diabetes,
right,
or, an autoimmune issue. So you've got to be really careful when there's a new medication that it's not going to tip the scale with another medical issue.
Oh, that makes sense. Thank you so much, Nancy. I do see we've gotten some written comments as well on this final, we'll make this the final word on current treatments before we shift gears.
Yeah. So a few other comments that have just came through was, we got a comment from Amy from California, and said we are managing a whole bunch of symptoms, anxiety, depression, thyroid dysfunction, seizures, but we're not really treating the disease itself. We've heard from Jenny from the United Kingdom. She was on donanzaprazil, but that has been discontinued as it was judged it was no longer available to have any impact on her AD. And Jenny is a sibling and a caregiver. And then also Catherine from California said, I would be in a trial right now if they would let me, but I would not have to travel. I would not have to travel a long way. I've already had cortisone shots in my back, and so I'm not afraid of a lumbar puncture. I just hope to get the medicine and not the placebo.
Sure. Wow. Well, thank you, everyone, for helping share your current treatment approaches. With the remaining time we have, I want to shift gears and look towards the future as both in terms of your thoughts around participating in trials and what you're looking for from future treatments. So if you can, one last time for today, go to that polling webpage, www.pollev.com/DSAD PFDD. We have a pair of questions. The first here on clinical trials. So we'd like to get a sense of, have you tried to sign up for a clinical trial or research study for a new medicine for DSAD? Or has your loved one, for our care partners? And the options are A, no, I'm not interested. B, I haven't signed up, but I would think about participating in a trial. C, yes, I tried to sign up, but they told me I wasn't a good fit for the trial. Or D, yes, I signed up and I am part of a clinical trial for a new medicine. So these are clinical trials for new investigational medicines, study drugs. Please let us know your and your loved one's experiences with these types of trials and your interest in them. All right. Well, some final responses are coming in. No one so far is reporting that they are not interested in trials. We're seeing about 60% of the audience say that they haven't signed up, but they would think about it. So some interest there. About a third of the audience saying that they have actually tried to sign up, but they told they weren't a good fit for the trial. And then finally, about a little over 10% saying that they have signed up and were able to participate. So thank you so much. One more question here. So this is now focused on future treatments. As I mentioned earlier, while we all want a cure, for this question, since there isn't a cure yet, researchers are trying to make new medicines to help people feel better when they have DSAD. What do you wish a new medicine would do? And you can pick up to the top 3 things that you would like to see in a new medicine, short of that complete cure. The options are A, I wish there was a medicine that could hold off symptoms until I'm older. B, I wish there was a medicine to prevent symptoms from getting worse. C, I wish there was a medicine I could count on to help me feel better all the time for as long as possible. D, I wish there was a medicine that would help me keep my ability to talk well. E, I wish there was a medicine to protect my memory and thinking skills. F, I wish there was a medicine to keep me feeling like my old self. G, I wish there was a medicine to help me stay physically strong so I can walk well for a long time. H, I wish there was a medicine to help me stay independent for longer. I would like a medicine with fewer side effects. Or J, you'd like something from a new medicine other than the other options listed here that represents a top 3 thing that you'd like to see in a new medicine short of that complete cure for DSAD. So as it stands, while we're waiting for final responses to come in, it looks like the 2 top desires from our participants are medicine that could hold off symptoms until I'm older, so slow that progression to the onset of Alzheimer's. And then after that, protect my memory and thinking skills. And maybe number 3 here is preventing symptoms from getting worse, so even once they've started, keeping things more stable. But every single thing here, except for other, but everything that was offered as an option being in some number of people's top 3 desire for a future treatment. So here I'd like to thank everyone for doing the polling. I'd like to now come to the Zoom panel and do a little bit of a rapid fire round here. I want every one of you to weigh in on this important question of what you would like to see as a kind of your top wish for a future treatment short of that complete cure. So we'll just go around here. Maybe Michael, we'll start with you on this one.
Thank you. What I can tell you in my own view is that the most exciting research that's going on currently with cell cultures with extra chromosomes in the cells that have been cultured is the silencing, partially, not yet completely, but the silencing of the extra chromosomes. So this has happened with the 21st chromosome, which is the culprit in Down syndrome, the extra one. And that has already been demonstrated in cell cultures. How to get from that point to actually research in human beings is complicated, but I think this is the most exciting avenue that I can think of for the future. If you can imagine being able to turn off the extra chromosome in childhood, this would be the greatest dream that I can think of, because you would eliminate the problem. The problem would be solved at that point. So I'll stop there.
Yeah.
I can think of more things that would be great in early ages, but
Sure.
that would also be great in later ages.
Thank you so much, Michael. Nancy, coming around here, what's the kind of thinking about that? We gave you a big list of options, and it could be something else, but what's at the top of your list that you'd like from a new treatment for DSAD?
Well, I'm thinking about a medication that would have very, very few side effects and that would help people just, be calm, less anxious, help them just enjoy their days, help them to engage in activities that, made them happy, and gave them a good quality of life.
That sounds wonderful, Nancy. Thank you. Rosemary, your, what would be your top goal for a new treatment for DSAD?
The same as Nancy's, that we can have a medication that would help our children and future children become more independent and able to survive on their own.
Mm-hmm.
But it's hard because there's not anything around, and right now, medicine is not working at all.
Right. Well, thank you, Rosemary. Joe, same question for you. What would represent kind of a top treatment goal, given where you all are in your journey?
My vision would be for some medication to be proactive instead of reactive. Again, the trials that we were part of and that they're cutting funding on, they don't even let them start till they're 25, but they know in our community, in our children or our loved ones, that this is a big issue. And I mean, it's an issue in all society. Alzheimer's is a growing concern.
Right.
And, we're reacting instead of, trying to figure out and being proactive and starting earlier to, find the symptoms and find the markers and find the medication that works. And before they get to the stages of, not being themselves and not communicating and getting fearful and having anxiety and stuff like that. So my hope is that we can be proactive instead of reactive.
And Joe, just to clarify what you mean by that, are you thinking about something that would, if it were to delay those things, or is it, make them less severe, or I mean, I think we all would agree, something that would prevent them from ever happening would be the ultimate goal. But short of that, what is it, when you were thinking of something being proactive, what's the goal?
Again, there's a lot of research on Alzheimer's already, on trying these different medications and stuff like that. I don't think they're going to have the cure to wipe it out, but once they identify that the person has the markers, are starting to see the signs, the caregivers are pointing out that the signs are there. I believe my mom was on the medication that, again, it wasn't going to help her, but it was geared to not making it get any worse.
Right.
That would be, identifying starting earlier versus, seeing that they're, so late in the stage of the Alzheimer's that, the medication really is not timely and therefore not helpful.
Sure. Thank you so much, Joe. And Amy, last but not least here to close out our Zoom panel, what's on the top of your list for a future treatment?
Short of a complete cure, of course.
Yes, of course.
I'm going to go with what Kate would say. And I know that Kate would say something to preserve, if not restore, her thinking capacity. She misses reading. She used to be able to read at about a 4th grade level, and now struggles at a first grade level. She misses her independence, something that could restore her independence and her ability to navigate. She gets out of the van after her day program and gets out of the van and walks the wrong way to her own apartment. And this is a girl who used to be able to navigate a major bus system in a major metropolitan area. So she would say something that would help preserve, if not restore, her thinking skills.
So helpful.
And she's very proactive. We're actually members of the ABCDS advisory board, and she's looked over all of the client information, all of the patient information that goes out to participants of the studies to see if it's manageable and understandable for a person with Down syndrome. So she's very passionate about being involved in the research, even though she at this point would not qualify for a clinical trial.
Wow. No, thank you for sharing that, as well as those treatment goals. So helpful to hear what she would actually want herself. Thank you all, and just thank you to this whole panel for so many contributions this afternoon, helping us understand both your current treatments and your experiences with them, but weighing in on this important topic of what you want from future treatments. So really appreciate all of your contributions. We'll now close out our session of seeking this community's input by giving voice to those of you who have been writing in. Many of you have been submitting comments on this important question as well. So what are we seeing, Candy?
So I'll start with Pam from Illinois. So Pam is a caregiver, and Pam states, with a strong family history of Alzheimer's disease, I am very hopeful that by the time my 23-year-old daughter reaches 40, there are much better treatments available and customized solutions for people with Down syndrome. Next, you have John from Dallas, Texas. John states, as a parent of a 27-year-old daughter with Down syndrome, I am very focused on ensuring there's an effort to develop therapies for this disease with a specific focus on this population. It is an urgent need to develop treatments to address this increased risk and assist families who have already had a meaningful lifelong care burden. Then you have Pat from the United States. Pat states that for our 48-year-old son, slow down the symptoms of Alzheimer's disease. And lastly to share is Howard from Kansas City, Missouri. And Howard states that there are so many things that made his son, Lee, who passed away from Down syndrome, his Alzheimer's disease journey difficult. But one that stands out in particular is that there was no treatment to ease his last years or even a drug trial to choose to participate. Very powerful statements.
Thank you to everybody who has had raised their hand virtually here to have their voices heard. This now concludes our program of seeking your input, hearing your voices. It's been an incredible day. As the meeting moderator, I just really have to thank all of you, all of our panelists, our Zoom discussion starters, and then every one of you that's called in and written in. You all have really helped, pull back the curtain of what it is to live with for many decades, just waiting and fearing and anticipating, the inevitable of Alzheimer's. And then when it's there, the crush of all of the losses of everything that's been worked so hard over so many years to gain skills and, be such critical parts of your communities. And then see those things, stripped away piece by piece. It's truly tragic and heartbreaking, but we could never have understood it if it wasn't for all of you being so willing to share with us all. And so truly, from the bottom of my heart, thanks to each and every one of you. I know today will have an important impact. But at this point, it's now time to move to some of our closing remarks, starting with a summary of today, which is really an impossible task to try to summarize all of what's been discussed. But it's my pleasure to introduce my friend and colleague, Sarah Wicks, Sarah works really at the intersection of bringing multiple stakeholders, patients, industry regulators together to ensure that drug development really represents what's important to patients, and has been a critical team member in helping plan and organize today's meeting. So she's a perfect person to do the impossible and try to summarize today. So Sarah, over to you.
Thank you, James. The meeting opened with remarks from Candy Pickard, CEO of the National Down Syndrome Society and mother to a young son living with Down syndrome. Dr. Teresa Baracchio, director of the Office of Neuroscience at FDA, shared that this meeting will give the agency direct insight into the lived experience of Down syndrome-associated Alzheimer's disease, or DSAD, helping FDA to understand what outcomes matter most to individuals and their families, what treatment benefits are meaningful, and what risks may be acceptable as therapies are developed. We then heard from Dr. Brian Chicoine, Medical Director of the Advocate Medical Group Adult Down Syndrome Center, who explained that people with Down syndrome are living longer and healthier lives than ever before. However, this increased longevity has also brought a significantly higher risk of Alzheimer's disease, with symptoms often emerging in the early 50s. Adults with Down syndrome have a 50 to 80% chance of developing Alzheimer's disease after age 65, and it is estimated that approximately 20 to 30,000 people are living with DSAD in the United States at any given time. In the morning session, we heard from individuals living with DSAD, family caregivers, siblings, and parents of both affected adults and younger individuals with Down syndrome who worry about what the future may hold. We also received several comments from patients and families during the live discussion. Their stories reflected different stages of the disease journey, from those living with active symptoms to families focused on prevention and early detection. Participants described a wide range of symptoms associated with DSAD. Among those discussed most often were mood and behavioral changes, including anxiety, frustration, anger and agitation, withdrawal, and even emotional outbursts that often seem to occur without a clear cause. One participant shared that she gets frustrated every day. Participants also described the frustration that comes from losing abilities and no longer being able to do things they once enjoyed or accomplished independently. Individuals spoke about feeling discouraged as everyday tasks became more difficult. One participant shared that they felt like she doesn't have control of her own life anymore. Changes in mobility and physical functioning were also discussed frequently. Participants described increasing fatigue, gait changes, balance problems, falls, and seizures, with some families reporting rapid physical decline. While memory loss is often associated with Alzheimer's disease, participants noted that trouble remembering and confusion occurred alongside many other symptoms. As the discussion turned to daily life, it became clear that these symptoms combine to reshape nearly every aspect of daily functioning. Participants described losing access to activities, programs, sports, employment, and community involvement that had long been important parts of their lives. Many could no longer participate in day programs, Special Olympics, volunteering, or hobbies they once loved. Participants also described the impact of losing the ability to communicate as they once had. As speech became more limited and finding words became more difficult, conversations grew shorter and relationships became harder to maintain. Many also described needing increasing assistance with bathing, dressing, medications, and other daily activities they once managed independently. Families spoke about the gradual loss of skills that had taken years to learn and maintain. Looking ahead, participants spoke openly about their fears for the future. Many worried about losing the ability to communicate and connect with their loved ones. One participant living with DSAD shared, "I worry that I'm going to lose my words." Others worried about losing independence, memory, and the ability to think clearly. Families described uncertainty about how quickly symptoms might progress and what supports would be available to them in the future. Parents of younger children with Down syndrome or young adults with Down syndrome shared that the risk of Alzheimer's disease influences planning for adulthood, employment, independent living, and long-term care decades before symptoms ever appear. Overall, families described a disease that affects communication, memory, personality, independence, and relationships. Many spoke about the challenges of living with symptoms today, while others described the fear of knowing that Alzheimer's disease remains a likely part of their future. In the afternoon, we heard from Dr. Michael Raffi, Medical Director of the Epstein Family Alzheimer's Therapeutic Research Institute, who shared that FDA-approved treatments are available for the treatment of Alzheimer's disease and dementia, though little is known about how effective these therapies are for people living with Down syndrome. He also discussed ongoing efforts to better understand and develop treatments for DSAD. The afternoon discussion turned to treatment experiences, research participation, and hopes for the future. Participants living with DSAD described relying on a wide range of medications and supportive interventions to manage symptoms. Traditional Alzheimer's disease medications, medications for anxiety, mood changes, sleep disturbances, seizures, and other behavioral symptom management were commonly discussed. Beyond medications, family described using visual aids, calendars, structured routines, exercise, diet, brain health games, and occupational and other supportive therapy to maintain daily functioning. Others described changes in living arrangements, additional staffing support, and adaptations designed to help individuals remain engaged in their communities. At the same time, participants emphasized the limitations of current treatment approaches. Many described managing individual symptoms while continuing to experience progression. Others described that medications that initially appeared helpful, but later lost effectiveness as symptoms progressed. Participants spoke extensively about clinical research and the hope it represents for individuals and families affected by DSAD. Many participants and families described actively participating in natural history studies, biomarker research, and imaging studies. Participants expressed a strong willingness to participate in research, even when studies involved significant burdens. Families described traveling long distances, undergoing invasive procedures, and taking time away from work and daily responsibilities to contribute to scientific progress. One participant living with DSAD stated, "I would be in a trial right now if they would let me." Participants also described challenges that can make research participation difficult, including geographic distance from study sites, limited access to trials, uncertainty about eligibility, and the disappointment of studies being discontinued. Several families emphasize that people with Down syndrome are eager to participate in research and should be treated as valued partners whose contributions matter. Many described participating not only for themselves, but for future generations of people with Down syndrome. When asked about future treatments, participants consistently expressed a desire for therapies that could delay the onset of symptoms or slow progression before substantial losses occur, particularly given the extraordinarily high lifetime risk of Alzheimer's disease among people with Down syndrome. Participants consistently identified memory, thinking, communication, and personality as abilities they most wanted future treatments to preserve. Participants also emphasized maintaining independence, preserving mobility, remaining engaged in work and community activities, and continuing to live happy, meaningful, self-directed lives. Throughout the day, participants described lives filled with work, friendships, athletics, creativity, independence, and community. Many spoke proudly about their careers, volunteer work, athletic accomplishments, artistic pursuits, independent living, and meaningful roles within their families and communities. They worried about losing words, independence, connection to loved ones, and activities they enjoy most. For many, Alzheimer's disease threatens abilities, relationships, and opportunities that were built over a lifetime. Several self-advocates also described the experience of watching friends with Down syndrome develop Alzheimer's disease, decline, and in some cases pass away, making the possibility of their own future diagnosis feel deeply personal and immediate. Families spoke about living for decades with the knowledge that their loved ones with Down syndrome face an extraordinarily high risk of developing Alzheimer's disease, a reality that shaped how they think about treatment, research, and the future. Several participants described the emotional burden of constantly watching for signs of Alzheimer's disease in their loved one, wondering whether changes in behavior, memory, communication, or daily functioning might signal the beginning of decline. Many parents described the unique challenge of supporting adult sons and daughters through Alzheimer's disease while they themselves are aging, creating concerns about caregiving, long-term support, and what will happen as both generations grow old. Participants expressed an urgent need for therapies that preserve abilities, maintain independence, and slow progression, while also emphasizing the importance of earlier detection, preventive interventions, and research opportunities before symptoms begin. Although many described challenges participating in research, they also made clear that the Down syndrome community remains eager to contribute to research that may improve outcomes for current and future generations. Participants repeatedly emphasized that people with Down syndrome are living full, engaged, and meaningful lives and deserve the same urgency, attention, and access to effective treatments as anyone else at risk for Alzheimer's. Thank you to everyone who shared their story today. Your honesty, courage, and willingness to speak about both the challenges and hopes associated with DSAD provided invaluable insight and will help to ensure that the voices of people with Down syndrome and their families remain at the center of these conversations. And now, to close the meeting, we'll go back to Candy in the studio.
Thank you for your insightful summary, Sarah. We've come to the end of an important day for our community, a difficult but important day. Talking about DSAD is tough. We have heard heart-wrenching stories. We've learned about beloved people whose lives were cut short. We had some complicated conversations, and we're taking steps to find the best solutions. And today was an important step towards these solutions, and gathering as a community to highlight these challenges and raise up the voices of those who are impacted by DSAD. We demonstrated our focus and our tenacity as a community. So I leave this meeting with hope for the future, and I hope you do too. Thank you to the FDA staff who attended the meeting, to Dr. Baracchio for her welcoming comments, and to Will Llewellyn from the FDA's patient-focused drug development staff, who expertly guided us in developing this meeting. And thank you to Sarah Wicks and James Valentine from Hyman, Phelps, and McNamara, whose assistance in planning and moderating today's meeting has been invaluable. We're grateful for not only their professional expertise, but for their personal kindness and empathy as well. A thank you to the entire team at Dudley Digital Works for their outstanding work in bringing the production elements together for today. And we're indebted to our subject matter experts, Dr. Brian Chacoin and Dr. Michael Raffi, for being with us today, as they are every day tireless champions for the health of our loved ones with Down syndrome. And we have a small but mighty team at NDSS who worked collaboratively to bring this project to fruition, and we're grateful for their work. But the initial driving force behind today's meeting was our unforgettable effervescence VP of Research and Clinical Operations, Lois Kelly, who died suddenly in April. Lois would have been so proud of all of the valuable conversations that happened here today. And finally, thank you to you, the Down syndrome community, to all the individuals and family members who spoke here today, to those who called in and those who sent comments, thank you. As you have done so on many occasions, today you gave your time, your energy, and your truth to a shared cause. This meeting is meaningful because of each and every one of you. And if you've been listening in but haven't yet shared your perspective, the form to submit comments will remain open for another 30 days. So please consider submitting additional comments before July 1st. In the coming weeks, the NDSS team will compile all of the information from today, including polling data and the comments, into a Voice of the Patient report, which becomes the formal record of the meeting and a reference for the future FDA work on this topic. When it is complete, the report will be shared on our website. And today's program will be available on demand immediately following this meeting at the same link you are on right now, and we invite you to share this program with others. Lastly, it has been my honor to support this meeting, which will have a lasting impact on the future of DSAD research and medical product development. So once again, to the entire community, thank you for making your voices heard today.